an infertility specialist. I, Dr. Neeti Tiwari, am taking care of this SIG as a convener, and I have two very dynamic co-conveners with me, Dr. Neelam Bapna from Rajasthan and Dr. Parul Garg. The SIG PCOS has decided to go do a lot of activities during their tenure of 22-24 under the guidance of our dynamic president, Dr. Pankaj Talwar, and Secretary General, Dr. Shweta Mittal. And this is our first attempt. This is our first webinar. We are going to have webinars on different aspects of PCOS, and we decided to start with adolescent PCOS. So I welcome you all once again. And Dr. Piki Saxena is a convener with me in this workshop, in this CME, and I welcome her also and thank her for being here with me. And Dr. Seema Mittal also for giving us this opportunity of collaborating with her IFS Haryana chapter. Thank you so much, and I hand over to Dr. Bhavani.
I would now request Dr. Pankaj Talwar, sir, President IFS, CEO at iHoma Fertility Clinics and ICAT Training Academy, to say a few words.
Thank you, Bhavani. Thank you so much. So I think it's wonderful seeing you all young guys here. And just a brief into what we actually do. We are a 4,400 strong group of gynecologists and doctors who do IVF and do within gynecology also. We got 20 SIG groups, which we have all over the country. And for this, we normally do some collaborations. And today we are collaborating with AOGD, as well as we are collaborating with the Haryana chapter and doing this meeting. So that's a backgrounder of our what this SIG is all about. This SIG is on PCO, and this is being mentored by Dr. Mala Arora. We all know about Dr. Mala Arora, and then we have Dr. Neeti at helm of the affairs. With Dr. Neeti, we have got Dr. Neelam Bapna and Dr. Parul, and Dr. Piki is representing AOGD. Dr. Ashok will be joining in some more minutes and time. Dr. Seema probably will be joining online. She's out of country. So I think Dr. Neeru is there from the Haryana chapter. Welcome, Dr. Neeru. And I like to welcome all of you on the behalf of IFS as the president, as one of the workers like you to this lovely meeting. It is on PCOS. Natasha is also here from the group. She raised her thumbs up. So great. So my message for you will be very simple, that when you talk about PCOS, I think in PCOS, nothing has changed in the past 20 years. We keep, thread by thread, we keep adding something, but nothing much has changed. The Rotterdam criteria, the modified ones, they're already, we all know. The NIH criteria, we already know. So nothing new has happened, but still we are always confused about PCOS. So what I would say is that as we are going on, we're focusing on adolescents today. Some protocol managements are changing, but basic things remain the same. When you talk to people confused, they can't even define PCO and PCOS and PCOD. They can't differentiate between the three. Talk to them about clomiphene. They don't know what is clomiphene sensitive, what is clomiphene resistant, what is clomiphene failure. Letrozole, what is letrozole? Protocols for PCOS and ovulation, and what is extended protocols for letrozole, what is letrozole failure of letrozole resistance. These terms are, though new, but they are being repackaged again and again. So my message for you as an elder brother will be that try to focus on the basic primary things. You should know how to diagnose PCO. What is hyperandrogenism? When to carry out free testosterone, when to carry out DHEA, when to carry out AMH. In adolescents, do we carry out AMH or not? That's always a burning issue. It should not be done as per the law that Neeti will be covering for you. Should we carry out an ultrasound? In case we have to do an ultrasound, which probe we have to use, abdominal or TVS? Then should we look at the follicle number per ovary or follicle number per section? What are the changing definitions? So I think we have to look at the whole thing in the totality and stick to the basics. And I'm very, very sure you're going to enjoy these meetings. And thank you so much for joining again. And thank you so much, Neeti and Piki, for giving me this opportunity. I enjoyed being here, and I wish this conference all the best. Thank you very much.
Thank you so much, sir, for your kind words. And it means a lot for us. You took out time from your busy schedule to join us today on this webinar. Thank you so much, sir.
Thank you. Thank you, Neeti.
I would now request Dr. Mala Arora, mentor for this SIG, to kindly give an introduction to the webinar.
Dr.
Welcome,
Mala
ma'am.
has joined. Dr. Mala has joined. Dr. Mala.
No, ma'am. No, sir.
No,
She's not here.
okay.
Ashok,
Has Dr. Ashok sir joined?
No, no.
we can request Dr. Neeru Thakral, who is from IFS Haryana chapter, to say a few words before we start with the webinar. Dr. Neeru?
Absolutely.
Yeah. Congratulations, Dr. Neeti, for this excellent
Thank you,
webinar,
Dr. Neeru.
first webinar of this PCOS. And we proud to have our president with us with lots of activities, so much on the young Turk, consular empowerment, and everywhere we are having so much activity, AI. So I request everyone to join the IFS. So many activities now are having daily anything. And hope will be definitely benefit by all this PCOS classification, adolescent PCOS everywhere here. And thanks for giving opportunity to Haryana to participate for this. And about Young Turk, I will say ki we are having Young Turk activity every second and fourth Friday. So everyone, all youngs who want to be having interest in the research, present a paper, how to paper, mentoring section, they can join us. They join the group. They tell us the article. We will select. We will guide them. We are always here. Dr. Pankaj, Dr. Shweta, they all are here. So we will definitely would like to help and grow your. So welcome everyone. Thank you, Dr. Neeti, for
Dr. Neeru. So we
making
can
this
start with the first session now.
Dr. Neeti,
As soon as Dr. Mala,
Dr. Ashok will be joining in 15-20 minutes. He's stuck in a very important meeting. So he said, you please go along.
okay. So we will, have him
You
with
can
us.
introduce him in after a session or something. Whenever, sir.
Okay, Dr. P. So before we start, I would like to tell the audience and the delegates who are here and all the faculty members, we want this webinar to be very interactive. Please feel free to put your questions in the chat box. We all will benefit from each other. We will learn from each other. This is the whole idea of having this webinar. This is not a 15 minutes talk and things get over. We are going to discuss it. Whatever is coming to your mind, put it in the chat box. Thank you so much. And now Dr. Bhavani would start this first session.
So to start the first session, I would like to invite Dr. Neeru Thakral, ma'am. She is Director, Thakral Hospital and Morpheus Thakral International IVF Center, Gurgaon. I would like to welcome Dr. Neeti Tiwari, ma'am. She is Senior Consultant at Center of IVF and Human Reproduction, Sir Gangaram Hospital.
Thank you, Bhavani. So Dr. Mala Arora would also join us in a while, but today we have a very bright young speaker, Dr. Bhavani Shekhar. She's an associate consultant with me at Center of IVF and Human Reproduction, Sir Gangaram Hospital. She has done her FNB from our Sir Gangaram Hospital and is an alumnus of AIMS. She has won many awards for paper presentation and a very highly academic, active person in our IFS in our department. So Dr. Bhavani would be speaking on the dilemma in diagnosis of adolescent PCOS.
Thank you so much, ma'am. So the topic is she or is she not? There is always a dilemma while diagnosing adolescent PCOS. So I shall be talking on this topic. PCOS is the most common endocrine condition affecting 8 to 13% women of reproductive age and 6 to 18% of adolescent girls. Adolescence, as defined by WHO, is the period between 10 to 19 years of age that includes significant and critical changes in growth, development, and puberty. Diagnosis of PCOS in adolescents is both controversial and challenging due to the overlap of normal pubertal physiological changes with the adult PCOS diagnostic criteria, that is irregular menses, acne, or PCO morphology on ultrasound. Challenges include the risk of underdiagnosis, delayed diagnosis, and overdiagnosis. So the International Guidelines for Assessment and Management of PCOS 2023, which was a collaborative effort of various societies, including ESHRE, ASRM, Endocrine Society, Monash University. They came up with their first guideline in 2018, where the aim was accurate diagnosis of PCOS with optimal care, prevention of complications, and improved health outcomes from adolescence to adulthood. The key changes within the guideline recommendations include elimination of specific unnecessary tests and importance of identifying adolescents at risk of PCOS. So what is the diagnostic criteria as per the most recent recommendation for diagnosing adolescent PCOS? It includes only 2 criteria: irregular menstrual cycles and ovulatory dysfunction, and hyperandrogenism, which could be biochemical or clinical. PCOS cannot be diagnosed in adolescents unless both these criteria, irregular menstrual cycles and hyperandrogenism, are present. Pelvic ultrasound is not included in the diagnostic criteria for adolescent PCOS. Coming to irregular menstrual cycles and ovulatory dysfunction, we know that physiological maturation of the hypothalamo-pituitary ovarian axis occurs over the years. Ovulation and menstrual cycle in adolescents may not match those of women in the reproductive age. Ovulatory dysfunction can even occur with regular cycles, and if an ovulation needs to be confirmed, serum progesterone levels can be measured. So how does this guideline define irregular menstrual cycles? It says that it is normal in the first year post-menarche as a part of normal pubertal transition. From 1 to 3 years post-menarche, it is irregular if it is less than 25 days or more than 45 days. From 3 years post-menarche onwards, it is less than 21 days or more than 35 days or less than 8 cycles per year. And 1 year post-menarche, even if there is one cycle delayed by more than 90 days, it is regarded as irregular menses. Or in case there is primary amenorrhea by 15 years of age or 3 years post-thelarche. Now, coming to clinical hyperandrogenism, which is the second criteria. So to diagnose clinical hyperandrogenism, a comprehensive history and physical examination for symptoms and signs of clinical hyperandrogenism is a must. In adolescents, these signs include mainly severe acne and hirsutism. Why severe acne? Recommendation is based on the fact that mild comedonal acne is anyways common in adolescent girls. Severe comedonal or severe inflammatory acne with 10 or more lesions is uncommon in these girls, and this should be taken as a sign of clinical hyperandrogenism. Coming to hirsutism, we all know about the modified Ferriman-Gallwey score, which include 9 androgen-sensitive areas of the body: the upper lip, chin, chest, upper abdomen, lower abdomen, upper arm, thighs, upper back, lower back, and the hirsutism is scored from 0 to 4, where 0 hirsutism, and only terminal hairs need to be considered. So hair which are long, coarse, and pigmented, only those hairs are to be considered, not the vellus hair. And a level of more than equal to 5 to 6 indicates hirsutism, depending upon the ethnicity. So in Asians, the cutoff we choose may be higher, and in Caucasians it may be lower. So the cutoff can vary depending upon the ethnicity. However, cutoffs are mainly based on studies in adults, not adolescents. So adolescents may have lower scores due to reduced exposure time. And it is also important to acknowledge that self-treatment is common and that can limit clinical assessment. So history of any self-treatment is also very important. Coming to biochemical hyperandrogenism, it is of greatest value in patients who do not have signs or have very minimal signs of clinical hyperandrogenism. In most adolescents, androgen levels reach adult levels by 12 to 15 years of age. Total and free testosterone can be used to assess biochemical hyperandrogenism. Free testosterone can be calculated using assays or even by using total testosterone, SHBG, and albumin using a mathematical formula. This is known as calculated free testosterone. So recent meta-analysis have shown that calculated free testosterone and free androgen index, which is total testosterone upon SHBG into 100, has the best sensitivity and specificity to diagnose biochemical hyperandrogenism compared to all other tests. Laboratories should use liquid chromatography, mass spectrometry assays over the direct immunoassays, such as ELISA or radiometric assay, for assessing total of free testosterone, because they have limited accuracy. If total of free testosterone are not elevated, androstenedione and DHEAS can be measured, but they provide only limited information while diagnosing PCOS due to poor specificity. Androstenedione is mainly elevated in non-classical congenital adrenal hyperplasia, and DHEAS is a predominantly adrenal androgen, which shows significant elevations in androgen-secreting adrenal tumors. If androgen levels are markedly above the reference range, then other causes of hyperandrogenemia, such as ovarian or adrenal tumors, CAH, Cushing's syndrome, should also be ruled out. And we need to avoid assessing biochemical hyperandrogenism in girls on combined OCPs. These girls need a drug withdrawal of 3 months before testing for biochemical hyperandrogenism. What is the role of pelvic ultrasound in these girls for diagnosis? Pelvic ultrasound should not be used for the diagnosis in those with a gynecological age of less than 8 years. That is, in less than 8 years post-menarche, pelvic ultrasound is not recommended due to high incidence of multifollicular ovaries in this life stage. Because there is risk of overdiagnosis in adolescents if ultrasound criteria is included in this age group. And we also know that there are limitations in performing transvaginal ultrasounds in those who are not sexually active. Earlier guidelines said that transabdominal ultrasound can be used in these girls, but now the latest recommendation says whether abdominal or vaginal, there is no need to do ultrasound in adolescents to diagnose PCOS. What is the role of AMH? Although serum AMH levels in adolescents and adult women with PCOS are significantly higher than in those without PCOS, there are overlaps between the two groups, especially in adolescents. AMH assays have improved over time, and hence a new recommendation on the role of AMH in diagnosing PCOS has come, but that is only in adults. So in adults, serum AMH could be used for defining PCOM. However, in adolescents, specificity and accuracy are limited. Therefore, AMH is not recommended. Now, this guidelines talks about adolescent at risk of PCOS. So who are these adolescents? For adolescents who have features of PCOS, but do not meet the diagnostic criteria, an increased risk should be considered, and reassessment should be advised at or before full reproductive maturity, that is 8 years post-menarche. Reassessment is particularly important for girls with persisting PCOS features and those with significant weight gain in adolescence. This recommendation is based on the need to address isolated symptoms, such as if the girl has only irregular menses or only clinical hyperandrogenism, where diagnosis of PCOS is unclear, as pelvic ultrasound is not recommended. So these girls with only one of the symptoms is categorized into the at risk of PCOS category. This will avoid delayed diagnosis and also avoid overdiagnosis or premature labeling. It is also important to exclude other causes, keep other causes in mind while diagnosing adolescent PCOS, because all etiologies which can cause menstrual irregularities or hyperandrogenism in adolescents should be excluded, such as hypothyroidism, hypoprolactinemia, non-classical CAH, Cushing's disease, androgen-secreting ovarian or adrenal tumors. All these can cause menstrual irregularity or hyperandrogenism. So history and physical examination to look for signs of hypothyroidism, galactoria, glucocorticoid excess, or virilization are important in evaluation of an adolescent girl with suspected PCOS. And depending upon if we have a suspicion based on history and physical examination, we need to measure the thyroid profile, prolactin, 17-OHP to rule out CAH, salivary cortisol to rule out Cushing's. So all these may be considered to exclude other causes. And also if the androgen levels are very high, that is twice above the upper limit of reference range, then imaging is also required to rule out ovarian or adrenal tumors. Now, the take-home message is that normal pubertal development should be kept in mind while diagnosing adolescent PCOS. Diagnosis of PCOS in adolescents relies mainly on ovulatory dysfunction and androgen excess, no role of pelvic ultrasound in diagnosis. We need to avoid unnecessary investigations and avoid under as well as overdiagnosis. Adolescents at risk of PCOS should be identified and followed up. Thank you.
Thank you, Dr. Bhavani. We will address the questions at the end.
Am I
has
audible?
Dr. Abha joined? Shivam, Dr. Abha was having some issue in joining. Have you been able to help?
I have already sent the link, direct link also.
Shivam, let us
Shivam?
know when Dr. Mala joins. She's going to join in 5-10 minutes.
Ava ma'am joining.
Yes.
Hello?
Am I audible?
Yes, welcome,
Dr.
Abha ma'am.
Neeru, you can introduce Dr. Abha. Yeah.
It's my proud privilege to introduce Dr. Abha Majumdar ma'am. She's our mentor. She's Director, Center of IVF and Human Reproduction, Sir Gangaram Hospital, New Delhi. President Medal for Best Medical Graduate of the year 1970 to 75. Excellence Award Obstetrics Gynae by Hippocrates Foundation. Abdul Kalam Gold Medal 2015. Rashtriya Gaurav Gold Medal Award. Distinguished Teacher of Excellence Award by National Board of Education. Awarded as IVF Champion of the 2019 Icon of IVF of North India. And Best Integrated National Team IVF by Economic Times of India. Lifetime Achievement Award by IFS, Indian Fertility Society. Course Director for Postdoctoral Fellowship in Reproductive Medicine. Member of Editorial Board of IVF Worldwide. Peer Viewer for Journal of Human Reproductive Science. Member of Advisory Board for Journal of Fertility Science. Field of interest we all know in fertility, ART, reproductive endocrinology, endoscopy. So welcome, ma'am. Everything is blessed for you. So we all are fan and waiting for you, eager to listen from you.
Dr. Neeru, I think Dr. Abha has to be made a panelist. Whoever is helping us from backend team, please make Dr. Abha panelist so that she can unmute herself and share.
I have
Already
been
done.
just
Okay.
done it in one. Welcome, ma'am. Welcome, ma'am.
Welcome, ma'am.
Thank you
Welcome.
so much.
Ma'am, we have introduced you.
Yeah.
Can
I heard that. I could hear it, but I couldn't speak.
Okay,
Yes.
ma'am. So you can start sharing, ma'am.
Oh, I have to speak now. Yes, ma'am.
Yeah. You can start
Okay,
sharing.
then can you stop sharing my?
Vani, stop sharing. Yeah. Ma'am, just a minute.
Bhavani's lecture is over.
Yes, ma'am.
Yes, ma'am.
Oh, okay.
Yeah. It was a nice talk.
All set for you, ma'am. All right, thank you. So, further to Bhavani's talk, I'm going to talk on what's new in the management of adolescent PCOS. I hope everything works. Can you see my slide? Yes, ma'am.
Yes,
Okay.
ma'am. Yeah.
So when we say adolescents, who is adolescent? It is girls between 10 and 19 years of age. In this age group, body image, sexual identity, peer interaction are critical for the evolving personality. Apart from association with medical disorders and irregular menstruation,
features of hyperandrogenism in adolescents can have a very substantial impact on self-esteem and can cause psychosocial morbidity. They don't like to meet friends, they don't like to meet family. They have a lot of psychological setbacks, especially with the androgenic symptoms. Timely diagnosis and medical intervention may prevent health sequelae and contribute to psychological well-being. Now, this whole lecture which I'm going to give, I have taken the the help of the International Evidence-Based Guideline for Assessment and Management of Polycystic Ovarian Syndrome 2023. And this has the views of Monash University, ASRM, Endocrine Society, ESHRI, CRE, PCOS, and the European Society of Endocrinology. So many people have given us the gist for this, and that is how I am going to present this to you. I have changed over from slideshow only to get the name of all the societies. So when we have a PCOS girl and we need to manage her, what do we as health professionals need to know? We have to learn to be very truthful, give correct information and education on PCOS at all levels of health professional training to address knowledge gaps. And I will tell you what are the knowledge gaps. We tell PCOS girls, you take this treatment, you will become all right in 6 months or 3 months or 1 year. No, this is not there. PCOS is a genetically imprinted condition on us. And hence, it is not possible to say you will become all right. It is like wearing spectacles. If we say, wear spectacles for 6 months, your eyes will become all right. That's a wrong statement. Similarly, we need to give them correct information, and it should be tailored. It should be provided to all PCOS girls in a very respectful and empathic manner. Now, when we say tailored information, we do individualized embryo transfer, we do individualized controlled ovarian stimulation. Similarly, this information should be tailored to what that patient needs to know about her PCOS status in a very empathic manner. The diversity of the population should be considered when adapting practice paradigms. Now, I mean, whether she's a vegetarian, she's a non-vegetarian, whether they allow her to sort of go out and exercise, or you have to devise some method for her that she should be able to do some physical activity on a daily basis. Girls should be also counseled on the risk of misinformation and guided to evidence-based resources. Having said that, common presentation in PCOS adolescents which require management. So menstrual symptoms, you all agree that there could be delayed menses, there could be prolonged bleeding, there could be non-cyclical early or late bleeding. So this is the commonest presentation about menstrual symptoms. Then come the hyperandrogenic symptoms. Out of that, the most troublesome or the most high nuisance value symptoms are hirsutism, acne, and baldness. Baldness is generally frontal and very typical of PCOS girls. And there are weight issues. And these girls say their counterpart eats a little bit and they eat a little bit, but they gain more weight and the counterpart doesn't gain weight. With this comes psychological symptoms with a negative impact on body image. They start feeling negative about the body from their peers. And last of all is we have to initiate longitudinal monitoring for early identification of comorbidities of PCOS. What are the comorbidities of PCOS? Diabetes, hypertension, hyperlipidemia, risk of cardiovascular accidents, and endometrial cancer later in life. So these are the 5 comorbidities which we always have to from adolescents, and I'll tell you how you monitor all this. So management spheres, they are all interlinked. Like lifestyle management and weight issues could also address the menstrual symptoms and the hyperandrogenic symptoms, and altogether the psychological issues also. But I'm trying to separate and give you a little bit of information on all these management separately. When we talk about lifestyle management and effectiveness of lifestyle interventions, then it is the core focus in PCOS. And please do not start with that you have to reduce weight. Weight is not our issue. It is bringing in some type of activity in girls who have been, especially young girls, who have been diagnosed with PCOS. If you hit upon weight, come back to you. So there are benefits to healthy lifestyle even in the absence of weight loss. Why? Because metabolic health is always of concern, whether it is a lean PCOS or an obese or an overweight PCOS. So exercise alone or diet along with exercise and behavioral changes should be recommended. So all you do in diet, just don't tell her that stop eating. Just tell her 3-4 things which she can stop eating. Maybe all the C's, like, the chow mein, the chips, and the chocolate. So maybe we can start with the 3 C's. Just take them out of your diet. Eat early evening food. Don't eat after that if possible, and exercise a little. Go and play a game, swim, play badminton, cycle or something. These girls would be much happier if we tell them to do a purposeful exercise rather than something which is very, sort of tedious. And this will not only reduce their weight marginally, or maybe not reduce, but it will definitely improve metabolic health, which is central adiposity and lipid profile. And it will also maintain and prevent weight gain, and it may lead to modest weight loss. So please don't tell these girls that you have to lose a lot of weight, because they will run away. They will never be able to do it. One step at a time, and it helps them a lot. Those girls who are not overweight in the adolescent age group, the focus should be on healthy lifestyle and prevention of weight gain. Healthy lifestyle is only 2 things: adding a small little exercise to your daily routine, removing 2 or 3 junk things which they generally are fond of, especially adolescents, and eating a diet which finishes at night by 7:30 or 8 o'clock. Then we have menstrual symptoms. What are the most important menstrual? One is delayed menses, 2 mahina, 3 mahina periods. Prolonged bleeding. Once I start bleeding, I don't stop. And one is non-cyclical early or late bleeding. What are the main methods to treat this? One is oral contraceptive pills, metformin, progestogens, and inositols. Having said that, I'll devote one slide to all these. Combined oral contraceptive pills. Now, these have the most important role in adolescents. Please remember, when I'm talking about combined oral contraceptive pills, I'm talking about the normal oral contraceptive pills, not the cyproterone, acetate, or drospirenone containing ones. So they should be used only after clear diagnosis of PCOS to treat hirsutism and or irregular menstrual cycles. So I'm sure Bhavani must have told you how do we diagnose, and we need both the symptoms, irregular periods and hirsutism, to diagnose PCOS in adolescents. And first 3 years, the periods could be irregular. So we do not diagnose them to have PCOS. We always say they are at risk of PCOS. And once a diagnosis is made, we can start using combined oral contraceptive pills. Then please, there is no advantage of using high-dose ethinyl estradiol. So don't look at the progestogen, which is there in the pill. Look at the ethinyl estradiol, because this is the one which we want to minimize in PCOS girls because of their tendency towards metabolic syndrome. So all oral contraceptive pills which has ethinyl estradiol less than 30 microgram is much more desired in these girls rather than those which have more than 30 micrograms. The 35 microgram ethinyl estradiol is always associated with cyproterone acetate preparations and should be considered as second-line therapy over other CPs, because we need to balance benefit of this oral combined pill to the adverse effect, which would include venous thromboembolic risk, metabolic risk profile, side effects, cost, and availability. Because we are not talking about 1 year of oral contraceptives. We are maybe talking about 20 years of oral contraceptive, 10 years of oral contraceptive. And hence we have to see in the long term, how are these contraceptives going to affect the metabolic risk profile of these young girls later in life. Now, PCOS-specific features such as obesity and cardiovascular risk factors need to be considered when we are prescribing combined oral contraceptive pills. So if the girl is already obese, she has history that her father had stent, her mother has hypertension. So already it is a family which has metabolic syndrome and is at risk for cardiovascular diseases. If this is so and you are going to prescribe a long-term pill, let it be a low ethinyl estradiol pill. Then we come to metformin, the so-called wonder drug. In between, metformin had lost its importance, and now again it has regained a lot of importance, especially in young PCOS adolescents. So one thing I would want to tell you that before giving metformin, if you can motivate the girl to an active lifestyle, they have similar efficacy. The metformin is not superior to an active lifestyle intervention. You can do away with metformin if you can introduce active lifestyle intervention for her. Metformin does lead to mild adverse GI side effects and is generally dose dependent and self-limiting. So you have to start for a lot of girls with a lower dose. These are young girls, and if you give them something which will induce a lot of acidity and nausea and distension and loose stools, she will stop the medicine immediately. So you start with 50 milligram and do the increment weekly or bi-weekly. And extended release preparations may minimize side effects, improve adherence to the medicine. Maximum daily dose is 2 grams in adolescents. So giving a 500 milligram tablet is giving her a medicine in a homeopathic dose, which is not going to affect her as you want in the metabolic profile. So however, 2 gram maybe is for an adolescent who is also overweight or obese. We can reduce the dose to 1.5 gram, but it is now considered safe for long-term use. However, indications for ongoing requirement needs to be considered. We need to see we give it for 1 year, 2 years, 4 years, how long. Then comes long-term use may be associated with low vitamin B12 levels. So you always remember someone who's on long-term use of vitamin B12, especially if they are vegans. Vegetarians are generally there who are not vegans. They may not have so much of vitamin B12 deficiency, but you find it quite a bit in our population who's not on metformin also. And then where there is exposure that, this girl, 18-year-old, might become a diabetic early because she's overweight and her family has a lot of history. Here, we must look at B12 levels and replace it wherever we find it deficient. Then we come to a very important combination is we give combined oral contraceptive pill with metformin. Where do you use it? So combined oral contraceptive is better than metformin for management of hirsutism with irregular menstrual cycles. But metformin is better than combined oral contraceptives for metabolic indications in PCOS. So if there is mainly hirsutism and irregular menstrual cycles, contraceptive pills are better. But if there are metabolic indications like obesity and already her lipid profile is going high, or you find that, there is a very strong history of diabetes, then metformin is a good drug for such a girl. Now, we can give combination of both. It may be most beneficial in high metabolic risk group, including those with a BMI of more than 30 kg per meter square. And I'm sure most of you must have seen adolescent almost reaching this stage of BMI with maybe impaired glucose tolerance or high risk ethnic groups and hirsutism and irregular cycles. What are the high risk ethnic groups in our country? It is mainly the community which does, I would say, which is business person, mainly Agarwals, Guptas, some Pandits also. Maybe the lifestyle and the genetic profile is such that this becomes a high risk ethnic group. The Kashmiris have very little chances of metabolic profile being disturbed. So it is different ethnic groups which are more prone to develop metabolic risk. Now, where oral contraceptives are contraindicated or they are not accepted, so many mothers and grandmothers would say, okay, you give it for 2-3 months. I don't want my daughter to be on a long-term oral contraceptive, or it is not tolerated. The moment you give it, the girl starts vomiting. There, metformin may be considered for irregular menstruation and hirsutism, but it will have a lesser benefit. So what do you do? Progestogens. These come to our rescue after oral contraceptive pills and metformins have been considered. And they have a very, very important role in my clinical practice. I have like sort of surrounded my whole clinical practice on just these three drugs. Progestogens are, what are they? They could be a progestogen like norethistedone or medroxyprogesterone acetate, or they could be natural progesterone, the micronized natural progesterone, which is available as oral injectable and vaginal or rectal administration. And there are progesterone-only contraceptive pills also, marketed by Organon. So there are two symptoms which you will encounter in your practice. One is irregular long cycles with normal menstrual bleeding. The girl says, I don't get my periods for 45 days, 2 months, 2.5 months. Then I get a normal bleeding for 4 or 5 days. Another one is irregular long cycles that they don't get 45, 50 days periods. But when they get it, it is heavy menstrual bleeding. Both these groups need different method of management. The first group, what do? You say, okay, I've seen you, and you just need a progestogen for withdrawal bleeding every 20 to 30 days. Don't wait for 2 months for your periods to happen. The moment 20 to 30 days have passed, you will take this medicine for 5 days and you will get a withdrawal bleeding within 10 days of the last tablet. What are the two drugs which we use most commonly? Medroxyprogesterone acetate and norethistedone. The total dose is 100 milligram. So remember, it is 10 milligram BD for 5 days for either drug. And after the drug finishes, give them clear-cut instructions, wait for at least 10 days. If in 10, 11 days also there is no withdrawal bleeding, what do you think of? Either the endometrium was very thin when you gave her and she's not growing her endometrium after 30 days or maybe after 60 days also, or she's pregnant. So never rule out. I mean, always think of pregnancy also in these adolescent girls, which they could have at times unknowingly. Now, the second problem was irregular long cycles with prolonged or heavy menstrual bleeding. Here, they need slapping back of the endometrium, which is estrogen dominated. That is why they go on bleeding for a long time. So what do you use? I like to use a progestogen. However, in the US, they like to use micronized natural progesterone or progesterone only pill also. You have to use continuous and cyclically. So you use it for 21 days or 25 days and stop it, let the bleeding happen, restart on day 2, day 3, or when heavy bleeding is there, even day 1. And again, give it for the same duration, again, restart it. And there will be a time when the patient or the girl will say, oh, I have very normal bleeding on day 1, 2, 3. I started on day 3. And then when I leave it, the bleeding is like quite normal. I use 3, 4 pads a day. That is the time when you know that you can probably now put her on a oral contraceptive pill. And suppose you have given progestogen for 3 months and yet her bleeding does not become normal and she's still bleeding very heavily. So what do? Then you introduce an ultrasound. You look at the endometrial thickness. You rule out a submucous fibroid or polyp in the uterine cavity. Or you may also need to do a local examination, even if it is under anesthesia, it is right, to rule out a cervical reason for bleeding. And I have had a patient once, which I published many years ago in our Foxy journal. She had a small fibroid at the cervix, which used to go on bleeding, and I was fed up of giving her progestogens. Nothing helped her. And then we did a UA, found this small little fibroid jutting out in the cervix and removed it. No ultrasound could see this fibroid because it was almost, outside the cervix. Now, what is the role of ultrasound if you look in a bleeding phase of a girl? If any time you can see her day 4 till day 12, if bleeding is continuing, whenever you put the ultrasound, I mean, maybe it is day 12, and you put an ultrasound probe over her abdomen and you find that her endometrium is more than 5 millimeter, it is 6, 7, 8, 9, 10, whatever. The best way to bring her endometrium down to normal is give her progestogen or natural micronized progesterone to revert or prevent endometrial hyperplasia. I give it cyclically, like I told you earlier, and you can give it for multiple cycles also. Now, if you find at that time it is less than 5 millimeter, means 4, 3 or 2, here also the history is there that she bleeds normally, then you can start medroxyprogesterone acetate withdrawal any day between day 21 to 35, 10 milligrams BD for 5 days. Our aim is that she should get about 8 periods in a year. So you can always tell her that, you can wait for 35 days. If your periods don't start on their own, you start medroxyprogesterone acetate for 5 days, and in another 7 days, you will get her period. So ideally, it becomes 45 days, one cycle she gets, and she can continue this. If she wants more cycles a year, she can start a little earlier, start from day 30 or day 25 or day 21. Or oral contraceptive pills are very good for these girls for 21 days. So the endometrium is normal. They don't bleed unlessly, and you put an ultrasound and it is 4 mm or less. Then you give them a withdrawal with medroxyprogesterone, or you put them on low dose oral contraceptive pills for 21 days. Beware of only one thing. Endometrial hyperplasia occurs by prolonged unopposed estrogenic stimulation of endometrium. Untreated estrogen excess in PCOS without progesterone exposure is associated with increased risk of endometrial cancer. Don't be surprised of getting this. Generally in adolescents, it's not common, but in 20s, I've seen multiple cases where the family was averse in giving hormones or OCPs to the girl, developed developed endometrial cancer in her 20s, only at 26, 27, 28, because she always had delayed periods and went on bleeding and then again had delayed periods. Anyways, I would not leave the last drug here, inositol, which is which is a favorite drug for a lot of my colleagues. However, I have never used it in my life. So I found a lot of literature on this in this PCOS guideline 2023, and they wrote inositol given on individual preferences of probably the gynecologist and the patient, because it has limited harm and it has potential for improvement in metabolic measures, yet with very limited clinical benefits on ovulation, hirsutism, or weight. So it has very little clinical benefit on all this, but yes, metabolic measures, it might help. Then 2 is metformin is to be considered over inositol for hirsutism and central adiposity, though metformin has more GI side effects than inositol. Women taking inositol and other complementary or nutritional therapies. So in this review, they have considered inositol as a nutritional therapy or a complementary therapy, must inform their health professionals about it. And they have not described the specific types of inositol, the doses or combinations of inositol, because they feel that there is lack of quality evidence, and hence they have not been able to tell us what doses and in what combinations inositol should be used. So we come to the next part, management of hirsutism. And you see, there is a lot of overlap. I made a chain picture. It is all interlinked. Hirsutism management goes along with menstrual management, and we try to reduce the number of drugs given to these girls. So hirsutism, if you see pharmacological interventions, number 1 is combined oral contraceptive pills. And the best is a low dose. But then if you feel that metabolic risk is not very high, then maybe we can go for oral contraceptives, which have anti-androgenic progestogen. So anti-androgens are there, topical therapy is there, and then cosmetic measure and direct hair removal, you all know about it. I will come to combined oral contraceptive pills. And here, this script has been taken from ACOG Committee Opinion 2019, where they say treatment of acne and hirsutism should not be withheld during ongoing longitudinal evaluation for at-risk PCOS. So the girl is at-risk PCOS, but she's come with a lot of hirsutism and acne. So you should start treating that. And here they say that hormonal therapy should not be started before menarche. So once menarche comes in, then only hormonal therapy to be started. But the revised PCOS guidelines say that it should be started once the diagnosis is made, and which is if the diagnosis is made, say, within 3 years of menarche, after 3 years of menarche. However, if response is suboptimal after 6 months of hormonal therapy. And when they say hormonal therapy, it could be spironolactone also. Additional hair removing therapies or anti-androgens can be added. So here they say add anti-androgens or hair removal therapies only if response is sort of suboptimal. For moderate to severe hirsutism, hormonal therapy and anti-androgens can be started concomitantly. So when they say hormonal therapy and anti-androgens, then they mean that anti-androgen containing OC pills or OC pills with anti-androgen like spironolactone. Any estrogen containing therapy should be more effective at reducing acne, particularly for adolescents with premenstrual acne flare-up. So it is estrogen which reduces the acne, and it is the anti-androgen which reduces the hirsutism. Anti-androgens are used to treat hirsutism in the presence of other effective form of contraception. So if you are using anti-androgens not as OC pills, but as the medicine itself, then you need to use some type of contraception, even in adolescents, where they would never admit to having a sexual exposure, but it is then maybe best to give it as OC pills. So anti-androgens usage is based on recommendations. Spironolactone is given in the doses of 25 to 100 milligram a day, has lower risk of adverse effects. Cyproterone acetate and drospirenone used as OCPs in my country. Cyproterone acetate is available alone also in some countries. Finasteride has an increased risk of liver toxicity. Dose is 5 milligram a day. Increased risk, but you rarely see it. Flutamide has a very high risk of severe liver toxicity, dose 250 to 750, and it is not used. So the first 4 drugs are used: spironolactone, CPA, drospirenone, and finasteride. These are the preparations. The only drospirenone containing low estradiol drug is Yaz. So see if Yaz is available locally, then it has ethynyl estradiol only 20 micrograms with drospirenone 3 milligrams. DHA, everywhere we have CPA 2 milligrams, and ethynyl estradiol is generally 35 micrograms. So I mean, if you don't want to use it as a combined OC pill, then in places it is available as 12.5 milligram or even 100 milligram, which is now not available. In the beginning, 100 milligram was available. Spironolactone is aldosterone antagonist, not taken as a OCP, can be used in combination with the OCP doses, 50 to 200 milligram daily. Side effects could be, it would still lead to irregular menses. So you will need to give something for irregular menses. And if there is a risk of that the girl could be exposed to a sexual assault or a sexual contact, then we need to give her a OCP also. I'm going to tell you about topical eflornithine. Now, this is FDA approved. It is 13.9% cream, irreversible inhibitor of ornithine decarboxylase, which is an enzyme essential for hair growth. It can be used as monotherapy for mild cases of facial hirsutism or as adjunct to other therapies if there is more. Effect is seen in 4 to 8 weeks. Reversal of hair growth within 8 weeks of discontinuation may happen. Doses twice, application at least 8 hours apart, and the trade name is Eflora Hinder Ellen Vaniqua. Now, the most important thing with topical eflornithine is that you can combine it with any of the drugs like drospirenone, CPA, because they act on the ovarian source, and this acts on the periphery. Mechanical laser light therapies for hair reduction. You all know so much about it. I don't need to tell you anything. But, you know, just doing this reduces facial hirsutism, but it is very therapeutic for related depression, anxiety, and quality of life for a lot of girls. So just treating the facial hirsutism mechanically also. And we have to remember that PCOS girls need more treatment sessions compared to idiopathic hirsutism. And it is very important that wavelength and delivery of laser treatment varies by skin and hair color. Laser is relatively ineffective in women with blonde, gray, or white hair. So beware very fair girls, it would be less effective in your patients who are very light in color. Additional of combined oral contraceptive pill with or without anti-androgens to laser treatment may improve the overall look of the girl and maintain it for longer. Mechanical hair removal with intense pulse light should be considered, but the benefits are less, and we should not use home-based IPL kits. Having said that, management of hirsutism in a nutshell is multimodal therapy is most effective approach to the treatment of hirsutism. So just don't put them on one medicine and say, wait. While they are waiting, they can go for some type of local treatment, maybe laser, hair removal, waxing, something like that. And this includes lifestyle changes. So physical hair removal and androgen suppression or blockage, everything should be done. So you've done lifestyle changes, you physically removed the hair, androgen suppression is done with a medication that slows or prevents new hair growth. Hormonal therapy not to be started before menarche, but once you started, the effect will come in 6 months. So some type of local treatment is very important. Any estrogen-containing therapy should be effective at reducing acne, and OCPs particularly are effective for adolescents who report premenstrual acne flare-ups. So patients should be assessed at routine intervals every 3 to 6 months for adverse effects and response to treatment until they are stable, when they should be monitored annually. I normally tell my patients of hirsutism, take a selfie for all areas where you have excess hair. And then after 6 months, you can take another selfie and then compare the two. Monitoring of serum androgens is not recommended. You can only see the hirsutism, which is what they have. You may or may not grade them also, but it is important to know that yes, it has reduced visually. So last is psychological therapy, which Dr. Roma is going to tell us in detail. I only want to highlight two things, that adolescents with PCOS who have depression, anxiety, disordered eating, body image distress, low self-esteem, or psychosexual dysfunction should be offered cognitive behavior therapy wherever appropriate. Psychological therapy could be considered first line management, antidepressant medication second line, preferably mostly in adults. Lifestyle intervention and other therapies like oral contraceptive pills, metformin, laser hair removal, targeting PCOS symptoms are important because they also improve psychological symptoms, and not managing anxiety and depression may impact adherence to PCOS treatment and management. So please be tactful with these young girls because they are anxious, they are depressed. So you have to talk to them in a very positive way, not impose a lot of do's and don'ts on them. Then only they will adhere to your treatment. So ACOG recommendation for adolescents in 2019 is that hirsutism and acne should be taken seriously because of the effect on self-esteem and quality of life and potential for psychosocial morbidity. No clear consensus guidelines on diagnostic criteria for PCOS in adolescents within 2 years of menarche. Thus, gynecologists should exercise caution in assigning this diagnosis prematurely. Treatment of acne and hirsutism should not be withheld during the ongoing longitudinal evaluation for possible diagnosis and confirmation of PCOS. Finding of polycystic ovarian morphology on ultrasound has a prevalence in adolescent girls in almost 40%, and it is not predictive of presence of future development of PCOS. So please do not use ultrasound to see polycystic ovarian morphology in young adolescents. Pelvic ultrasonography is not routinely indicated unless serum androgen levels or the degree of virilization is so much that we are concerned for an hormonal ovarian tumor. Now, follow-up of PCOS diagnosed at an early age. This is how I follow up. I haven't found this anywhere. It is, I tell them to buy a weighing machine, take their weight once a week, keep it in the bathroom. And the moment the weight goes up by 1 to 2 kg, they should have an alarm ringing in their head and reduce this weight, because once the weight goes up by 10 kgs, it would be very difficult to reduce it. Ensure menses at least every 40 to 45 days. OGTT should be done yearly, not just fasting sugar or not just hemoglobin A1C. Blood pressure should be seen yearly for these young girls. Lipid profile should be done yearly. Having said that, adolescents have a long way to go, and wrong diagnosis or a very premature diagnosis of a disease which they are so afraid of socially, they hear horror stories of PCOS from their friends. They can make their path difficult. Thank you very much.
Thank you so much, ma'am. Or as always, a very nice deliberation. There were a few questions in the chat box by Dr. Manisha Jain. She wanted to know, as per the conventional teaching, we should give withdrawal for 10 days with progestogens, at least in long amenorrhea patients, especially
No,
in ovulatory.
no, it is only the dose should be sufficient of progesterone, and it is 100 milligram dose divided in 2 or 3 doses, whatever way you want to give. But you have to give adequate dose. If you give a lower dose, then you can go for 10 days. If you want to give 10 milligrams every day, then give it for 10 days and then wait for another 7 to 10 days. All right, Manisha?
And another question is, ma'am, from her only, that she wanted to know that there's some patient who routinely come for a pregnancy counseling, pregnancy counseling, and they incidentally find PCOS with a thick endometrium. Do they need a biopsy?
I think a biopsy is only needed if a thick endometrium doesn't shed completely. So the most important thing is to repeat your endometrial thickness on day 3 or 4 of menstruation. And if it is anything like 4 or 5 millimeter, they don't need a biopsy. A persistent endometrium after shedding, if is more than 7 millimeter repeatedly, definitely needs a biopsy. This is the cutoff which we have read in all books.
Ma'am, one more thing I want to you to tell everyone that how do you monitor patients on metformin? If you have started the young girls on metformin, how do you monitor them?
It is mainly, what I tell them is unless you do not start lifestyle interventions, metformin will not work. My example to them is in a swimming pool, if we start lot of waves from right to left and tell the girl to swim from left to right, she will face a lot of resistance. But if we can stop the waves, she will swim easily. So metformin only stops the waves. She will still have to swim to the other side. So she will have to have some type of exercise, good amount into her lifestyle for metformin to work best for her. So if she just keeps on taking a suboptimal dose of metformin for years also, the metabolic profile will not change, Niti, and it will not even help her in weight loss. But if she is exercising with metformin, she will lose weight faster and her metabolic profile will also change much faster.
Do we need to do any tests, ma'am, by the
No.
patient on
I
metformin?
don't do any test. It's just this that I look at her BMI, I look at her central obesity, and if she's got something more than just irregular menses and hirsutism, metabolic syndrome, if these girls have, they have acanthosis, there's a family history of diabetes, even if her blood pressure is normal. I mean, so many girls in adolescents who are very overweight, I find the blood pressure already mounting up. This
Yeah.
is good enough to say that metformin in a full dose, that is 2 gram daily, whether it is slow release or normal release, has to be given.
Thank you, ma'am. Thank you so much. It was wonderful to have you on board, as
Thank
always. And we have Dr. Ashok Kumar has also joined us. Sir is here. Dr. Ashok Kumar is the president of AOGD. We are honored to have him with us. Um, Bhavani. So Dr. Ashok Kumar is Director Professor and Head of the Department of Obs and Gynae, Atal Bihari Vajpayee Institute of Medical Sciences and Ram Manohar Lohia Hospital. We all know him very well. And he's presently the president of AOGD. Sir, we would like you to say a few words.
Uh, Thank you. First of all, Dr. Vicky Saxena, our chairperson of AOGD, she is a very good ambassador of AOGD, organizing many webinars on infertility and reproductive outcome. And this series on PCOS is always a need of the hour. And AOGD is also thankful to Haryana chapter of IFS and IFS for organizing this webinar. Dr. Pankaj Talwar, Dr. Shweta Mittal, and Dr. Mala Arora, and Dr. Seema Mittal. So thank you very much all having me here in your program. And always AOGD is interested in all academic activities, and we would like all of the participants to be updated about all the diseases and disorders of our women, so that they can provide good services and good outcomes to all of them. So thank you very much for having me here. I will not be disturbing you in between the webinar. So Dr. Vicky, please continue with your program. Thank you so much.
Thank you, sir, for the kind words. And now I invite Dr. Mala Arora, who is the mentor of our SIG and a guiding force behind us. Dr. Mala Arora, so just say a few words before we go ahead with the next talk.
Dr. Neeti, Dr. Mala will be joining at the end.
Okay, I thought
not
she's
at the
here,
moment.
so I just
She's
thought.
there, but she is muted because she's busy in some very important thing.
Okay.
So at the end, ma'am can give the concluding remarks.
Okay. Then we go ahead with the next talk. We are looking forward to hear from Dr. Roma. So Dr. Roma Kumar is Senior Consultant Psychologist, Sir Gangaram Hospital, and she's also founder of the Saksham Mental Health Clinic. And she's profoundly known for her work on adolescents also. She has a lot of publications on them. And now I invite her to speak on the social issues of these children who suffer from PCOS.
At the end.
Thank you so much, Neeti, for the introduction. I'll just share my slide. And I think before I go on, I think Dr. Abha actually said a lot of stuff and she made such a good talk. I don't think I can do better than her. She's way too good on everything. So, of course, we've seen that, when a client comes to a psychologist is not for PCOS, certainly not for PCOS. And what they come for is various other areas of concern. So it's very difficult for a psychologist to start talking on PCOS immediately, but we pick up the symptoms and we start understanding what the problems the adolescent girl is going through. So we know that the adolescent is a holistic development where there's physical development, there's social development, and there's mental and emotional development also there. So all these three areas come into practice. And we know that adolescence is beyond the physical, and the PCOS is definitely going beyond the physical. Literature says that patients with PCOS have significant difficulties in their quality of life, and their scores are different from the ones, from the normal and the PCOS. So the diagnosis is most important, and it does have a very adverse impact on the quality of life, the emotional and social fitness. And most of the clients who come to the psychologist are mainly the adolescent is either going through anxiety or depression, or usually having an academic issue. So from there, we pick up most of the symptoms that the adolescent girl may be having. So what people actually think of PCOS is that being overweight or there's infertility. And whereas we see PCOS actually is having as hormonal weight gain, chronic fatigue, anxiety or mood swings. Of course, we've spoken of the hirsutism, there's excessive hair and acne. There's a lot of difficulty in falling asleep and also sustaining the sleep pattern. There is hair loss, and we know that there's irregular periods also, which the earlier speakers have already spoken about. So the PCOS iceberg, let's understand what that is. What is there which is visible and what is not there that is just completely invisible. The invisible part is the anxiety. Now, anxiety starts interfering with a lot of other areas of daily life. And the first area that the parent sees is the child not doing well academically, because the child is unable to concentrate well or is unable to perform and is having difficulty in sustaining a lot of friendships also. And adolescence, we know, is a period where we have a lot of infatuations, we have relationships, and we are growing with our self-esteem, our self-concept, our self-worth areas. So when the client comes into us, is either coming in because there's the feeling of isolation, feeling of depression, low self-esteem and confidence, and body image issues. There's a lot which has been talked about, brain fog these days, and there's poor interpersonal relationships, decreased appetite is a problem. There's a decreased sleep pattern is there. So all of these interfere, and that's why this is a hidden area. And very often when they have been referred to the psychologist, they come pretty late. So when they come very late, it gets tough to begin talking on the lifestyle changes or working on the anxiety and the depression area. The invisible part again is the low libido. We know that during this period, they are partying, they're clubbing, they're doing a lot of deal making on the Instagram, and they don't want to show themselves. They're quite overwhelmed with certain situations, especially in the peer interactions. Daytime fatigue is very often seen, so they are not concentrating in the classrooms. They are usually, when in a holiday mood, they are sleeping at a different hour. They are waking up hours are in the nocturnal time. Cravings and hunger are seen. I've seen clients where parents are reporting that she's all the time trying to eat and there's emotional eating happening. So that's another very big area of concern. Insomnia, sleep apnea happening. They are wired, but they're pretty tired. So that's the area that the psychologist actually works on, and works not only on the adolescent girl with the PCOS, but also works on the family, and also tries to understand that what exactly out of this whole thing is affecting them. And usually in history taking, they do not talk about the PCOS. It's only when we start talking about various lifestyle areas or their obesity or their hirsutism or acne, that's when it's an off mark that the parent will say, yeah, we had gone to the gynecologist. So for them, they're not talking about this area much. So left to the psychologist, we have to work on the area which is coming in more for like the anxiety or ghabrahat ho rahi hai, they start talking on that, or they're very sad. So those are the areas that we start working on. The body image battles. PCOS changes their bodies. We are well aware of that, which makes the adolescent girl feel very different from the other adolescents. They start feeling that they are not good looking. They start feeling that they will not be able to attract a lot of people. While with psychologists, we see that, they have started interacting on the social media platforms to the to groups on various areas. And also another area which is of concern because of the body image battles is the body cutting, which is happening very often. The second area is suicidal ideation is growing very high in adolescent girls with PCOS. So there's higher levels of body dissatisfaction which is coming up, and this needs to be really worked on. Many adolescents also report feeling that hirsutism actually taken away their, female identity. They talk of going to the parlor very often, or they are shaving their bodies, or many of them going for laser treatments, and they feel that, why them? Why me? Why am I affected by it? So somebody needs to listen to their issues more than just focusing on the body weight. And the physical changes actually erodes the self-esteem, and the anxiety and depression is very often seen. Some of it is hidden because a lot of people feel that people who are in the overweight, or the girls who are overweight, they're happy people. They make you laugh. They're fun to be with. But what's happening within them or within inside them, nobody actually understands. So when a adolescent girl comes for talking about these areas, it's important to address these areas so that, she doesn't feel very alien, or she's in, of course, sync with a lot of feminine ideas. Socially, because while in their growing years, they're going through this, they may face bullying, of course, isolation, and conform to unrealistic beauty standards. A lot of them spend a lot of money on cosmetic products, and leading to a lot of more inadequacies within themselves. We've heard from our ma'am also about the menstruation, that menstrual irregularities can be of significant distress. Fear of potential infertility weighs heavy on adolescent girls. A lot of families, the mothers start talking about if you have this kind of weight, you'll never satisfy anyone, or you're going to have fertility issues. So this keeps weighing on the child's mind, and further, this is going to lead to inadequacy, feelings of inadequacy and anxiety. And this uncertainty surrounding the reproduction can lead to persistent sense of worry, leading to a lot of stressful behavior. The emotional burden, the adolescents with PCOS are at a higher risk of, we know that anxiety and depression. And a lot of studies find that young women with PCOS have significant higher levels of depression and anxiety, and they have no one to talk to. Back at home, when we talk to the families, most of them are talking or focusing only on the weight or on her eating patterns. They're not focusing on what is it that is happening inside her. So emotional area, I always say that, in our culture, we don't talk about emotions. We don't allow our girls to talk about emotions. We're not allowing them to vent out what's happening to them. What is this doing to them? So rather than putting just a diagnosis, I think working holistically with the psychologist is most important, and also psychoeducating the family around the same topic. So uncertainty around PCOS is there's variable symptoms. All of them do not fall in the same symptomatology. The diagnosis is complex, and anxieties about their future fertility, long-term health complications, ongoing management of symptoms. So there's non-compliance quite often. The girl may have gone to the doctor, the girl has been given the recommendations for medication, and yet she's non-compliant because the family is probably non-compliant, or she's hearing from others that why should you be on these pills? And of course, coping and mental well-being. So there's uncertainty around a lot of these areas. The social domain, the fear of being judged or misunderstood is quite common, and that can make it difficult to confide in peers or creating a sense of loneliness and isolation. Bullying is another area. I've already spoken about it at length, and some families may not fully understand the condition, leading to misunderstandings and a lack of emotional familial support. So very often these girls would come and tell us that back at home, I have no support. So she wants to come and see the psychologist more often, whereas the family will tell the child, why do you need to go to the psychologist? You don't need the psychologist. You're unnecessarily spending money with the psychologist. The psychologist is only going to listen to you. We are there to help you. But on the other hand, there's so much dissonance in the same area. So the child gets further affected. Impact on the academic performance. That's where a lot of children come to us because of poor academic performance, and it can contribute to cognitive issues such as difficulty concentrating, impaired memory, chronic fatigue. Your energy levels are quite reduced, high levels of anxiety and depression. It affects your ability to focus, retain information, and perform well. And we are also aware that the menstrual pain can lead to frequent absenteeism from school or causing students to miss critical lessons and fall in their studies further. So what do we do about it? We're aware of this, but what do we do? So I think that's exactly what we are doing at this point, and I'm happy that all of you are connecting together and also working in a holistic manner. We need to reduce the stigma associated with PCOS, encourage an open dialogue, foster a more understanding and supporting environment, provide appropriate treatment, increasing the awareness, and managing symptoms better. We have spoken about a lot of these myths. I don't think I'm going to focus on this. The interventions are that psychological counseling and therapy. Most important is the cognitive behavior therapy that works the best in adolescents going through the PCOS syndrome. It promotes emotional health and also helps the child understand how to reach being mentally agile and having good resilience. Peer support groups are another area. Joining these support groups can help adolescents share their experiences, can reduce their feelings of isolation, and provide emotional support. We know that the peer group can actually give a lot of support to each other. In fact, these days I have adolescent peer groups who are coming themselves for for a peer or for somebody who they are friends with, that she needs help. And I feel that we are going that one step further. So it's important to psychoeducate the young youth, the school population and the family, how to address these areas in a holistic manner. PCOS education programs, which are structured programs that help the individuals understanding what PCOS is all about, its symptoms, and the strategies that can empower them with the knowledge. I am again and again talking of how it's important to talk to the family. Educating family members about the PCOS can actually foster a supportive and empathetic home environment. So that is the most important. Holistic and comprehensive approach will incorporate psychosocial interventions alongside medical intervention. And I think it'll help mentally and emotionally, and also give support to the individual who's going through this kind of a area of concern. Thank you so much.
Thank you so much, Dr. Roma. It was a beautiful talk and on a lot of aspects which we were not aware of. So thank you so much. And it was great to have you around. So with this, we will come to the end of this session. Any questions? Dr. Picky, you want to make any comments or?
I think it is a very much neglected part that you have focused on today. And I think Dr. Ruma had a beautiful presentation, which really we are facing. And we should be having more sessions, having psychologists along with us. It has to be a multidisciplinary management of PCOS all across the life stage, not just adolescent, reproductive age group, perimenopausal. So I think you made a very important point, and we should all focus on this also. And we should have, in fact, some red flags where we need to refer to you in case we find, sometimes these girls are very much under stress and distress. So what are those points? What are the points where we, like you said, the parents are saying, kuch nahi hai, don't worry about it. So what are those red flags? I'm sure parents and all of us are also very interested in the welfare of the child. So we need to refer to the psychologist. I think
Yeah, so from physiology, it becomes pathology.
Yes.
So we should know that till what extent it is normal stress and where it becomes a distress and needs a management by a psychologist and psychiatrist if required.
And I think the peer group thing that you said is very, very important, because they think parents don't know anything. But when the parents talk about their experiences, it makes a lot of difference.
Yes, friends are the most important, this thing for teenagers, all the teenagers.
Right.
The most important people are friends. So, yeah. Thank you so much. And with this, we come to the end of the first session. Now, I invite Dr. Bhavani to go ahead with the second session. Dr. Bhavani.
So now we will begin with the second session. And first, we'll have the panel discussion. The moderators of the panel discussion are Dr. Neelam Bapna. Ma'am is the co-convener of this SIG, and she is consultant PGYN at Shivani Fertility and IVF Center in Saket Hospital, Jaipur. I would also like to welcome Dr. Parul Garg. Dr. Parul Garg is also a co-convener of this SIG, and she is head of Department of Reproductive Medicine at Artemis Hospital, Gurgaon. And I would invite the panelists. I would request the moderators to invite the panelists.
Okay. Hello, everyone. Can I have a slide for the CVs of the panelists?
Dr. Neeti, Dr. Mala has also joined. I see her there. So if we can take a minute to introduce ma'am.
Yeah. We were waiting for her.
Yes.
Bhavani, can you just show Dr. Mala's slide? Bhavani, can you share the screen and...
Is my screen not visible?
No, Bhavani, we can't see. While you were reading the CVs of Dr. Neelam and Parul also.
Okay, I'll just a minute. Yes.
So Dr. Mala Arora, we all know her very well, but just to introduce her, she has been chairperson of ICOG 2017, and then afterwards, before that, she has been on board of various organizations. She has been heading. She was even vice president of FOXY in 2011, and presently, we are honored to have her as mentor of our special interest group. And Dr. Mala Arora, we would like her to say a few words of wisdom, give us a few words of wisdom on adolescent PCOS. Dr.
Yeah.
Mala, ma'am.
Hello. Can you hear me?
Yes, ma'am.
Yes, ma'am.
You're audible.
Yeah. So
Bhavani, stop
I think this
sharing.
is a very, very important topic you have taken up for discussion. And I know presenting with PCOS, and as the lectures have highlighted, it is so important to deal with them empathetically, sympathetically, and counsel them properly. I think one thing I would advise all practitioners, because we are busy, we may not be able to counsel them well. It is important we take the help of a counselor and a dietitian.
Yeah.
Lifestyle modification can change a lot of things. You're already all aware. But the important thing is be optimistic when you talk to them. Don't tell them all the problems that PCOS can cause, because they're already on the verge of depression. These adolescents that are overweight and emotionally eating are already on the verge of feeling low. They need an optimistic approach. And I tell most of my patients, all you need to do is change your lifestyle and PCOS will go away. Don't worry, it is not something that will stay with you. So I think my only message is wonderful deliberations. I really enjoyed them all. And I'm looking forward to the panel discussion. And I'm sure you will spread this message across that we have to be more optimistic when we talk to adolescents. Thank you.
Thank you so much, ma'am. Thank you for your inspirational words. And with that, now we move on to the panel. Bhavani, can you start showing the CVs of the panelists so that the moderators can introduce them? Bhavani, you are muted. Bhavani, you are muted.
So, good evening all. So I would like to invite our panelist. Dr. P.K. Saxena. She's a director professor of Obs and Gynae in Lady Hardinge Medical College. She's a winner of 34 gold medals and editor of 10 books and published more than 250 articles. The chairperson of AOGD and currently she's the executive member of IFS.
Thank you. Thank you, Doctor.
Can we have the next slide, please?
Hello.
Dr. Leena Vadhva, she's a professor, HOD Medical College, Alwar. She is credited with setting up of first IVF center at ASI Hospital. She is currently a treasurer of our IFS. Dr. Ruma Satvik, she is a consultant at IVF consultant, Sir Gangaram Hospital. And she has a various publications in international and national journal. Dr. Nitasha Gupta, she is a IVF consultant and a cosmetic gynecologist. She has received a gold medal in Fertivision and a RD Pandit National Award. I would also like to invite Dr. Neha Mishra. She's an assistant professor Obs and Gynae, RML Hospital, New Delhi. And she has received a Young Researcher Award and has various publications in international and national journals. Dr. Manishi Mittal, she is a senior consultant, Mittal Maternity and Nursing Home Center, Yamuna Nagar, and she's a secretary, Abhinanagar Obs and Gynae Society. Dr. Rita Bansiwal. She is a professor, Department of Obs and Gynae, Safdarjung Hospital. She received a KD Nair Best Clinical Repair Award, Paper Award, and also received an award for the highest tubal ligations done in a population week 2014 from Delhi. That's it. Okay. Welcome you all. So we start with the panel discussion. Let me share the slides. So as we do a daily practice, we encounter these adolescent PCOS, and so much of discussion has already been done. So we still have a dilemma in diagnosing the adolescent PCOS and when to treat them. Let's hope we can solve these queries through this panel discussion. So case one is the 16-year-old lady girl. This menstrual history is 5 to 6 days, occurring at every 60 to 80 days, that is irregular, since the age of menarche, that is 13 years. She has a history of hirsutism that has been increased over last 2 years, and she's been shaving every 2 to 3 days. There is also associated acne, and she has a family history. Her mother is diagnosed as a PCOS, and her mother brings her for further investigation as she is very anxious about her daughter may have PCOS. So on examination, BMI is 32, blood pressure is normal, and on physical examination, we found acne, hirsutism, and acanthosis nigricans. And there is no obvious Cushingoid features, and our physical examination otherwise is normal. On lab test, there's a LH is 10, FSH is 6, HbA1c is 5.9%, and 17-hydroxyprogesterone, DHEAS, total testosterone, and TST, thyroid stimulating hormone, and prolactin levels are normal. So other causes of hirsutism has been ruled out. So first question is, in adolescent, at what point after onset of menarche do irregular cycles indicate ongoing menstrual dysfunction? Dr. Peaky.
Dr. Parul, this is a very important question and it has already been answered in the previous lecture. But the latest PCOS guidelines 2023 clearly state that in the first year after menarche, you don't have to worry too much. But after 1 year and less than 3 years, if the child is having periods before 21 days or after 45 days, then that is thought to be abnormal. And after 3 years, like in this child, she had her menarche at 13 years and now she's 16. So beyond that also, if she's having less than 21 days or a period longer than 35 days, it is thought to be pathological. And the other thing is, if the girl is having primary amenorrhea by 15 years, till 15 years, or she has had her breast development and 3 years beyond that, if she does not menstruate, then that is also considered to be abnormal.
Yes, ma'am, this is rightly said. And irregular cycles and ovulatory dysfunctions are a normal component of this pubertal transition. So the defining this abnormality is very challenging during this period. And also these patients are already having a menstrual cycle. They may be ovulating or they may not be ovulating. So
it is very, very confusing, you know. It's a real
this is very, very confusing. Yeah.
The hypothalamic pituitary ovarian axis is not mature. So physiologically, they are having irregular cycles or they are having little bit of hair growth and weight gain and acne. So the problem is that sometimes they are labeled too early as PCOS. And on the other hand, sometimes you take it just as normal and don't treat it. So it is very important that this important issue should be highlighted.
Yes. So to diagnose the adolescent PCOS, so two features has to be there, either the irregular menstrual cycle plus hyperandrogenism. That can be clinical or biochemical. If either of these is there, then they are labeled as an increased risk. So in this, we have to reassess at 8 years post-menarche.
If the child is having moderate to severe acne, or if you on Ferriman-Galway scoring, if the score is higher than 6 and this persists, then even before 8 years post menarche, we can label them and ultrasound will not be necessary.
Yeah. So we move on to next question. In adolescent women with suspected PCOS, what is the most effective measure to diagnose the PCOS related to biochemical hyperandrogenism? Dr. Rita?
Yeah, am I audible?
Yes, yes.
Acha. Dr. Farooq is already actually this panel discussion is made very easier with the previous lectures. So already Bhavani has beautifully told that for diagnosing basically the biochemical hyperandrogenism, free testosterone or the calculated, the androgen index, those things are important to find out the basically, or if for the biochemical and hyperandrogenism. Otherwise, if she is frankly, institution is there, then we can diagnose that she is having actually hyperandrogenism.
So hyperandrogenism is a key diagnostic feature of PCOS affecting 60 to 100% of patients. And diagnosing the hyperandrogenism biochemically is challenging because there is a variation in methods, ethnicity, and there is a confounding factors like excessive weight and a life stage.
Many
And
times
also,
the PHRN is also not available. So we always tell them to do total testosterone instead of
yeah.
the free testosterone.
So they recommend the use of total and a free testosterone to assess the biochemical
Generally
hyper.
not available. It is not recommended to do a free testosterone. It can be assessed by doing free androgen index.
Free androgen index, right? That is the most
100
sensitive,
total
yeah.
testosterone divided by SHBG. But
Yes,
that is not necessary if the total testosterone is high. Then there is no need to go for free testosterone because SHBG also we are not getting it done.
Yeah. So for detection of hypoandrogenism in PCOS, biochemically is only important when there is no clinical signs. So we first see the clinical signs. If it is there, there is no need to measure the androgen levels.
Very important.
Yeah.
And also we have to see which lab they are going to.
Yes, that is also important.
It is recommended that it has to be done by liquid chromatography mass spectrometry, which is a very expensive. And most of the other labs are doing only radioimmunoassay or ELISA. So we should also see which lab. And only when required, as Dr. Parul said, we should get it done only when no other clinical signs and symptoms are there and the lady, the child is obese and we have a strong suspicion of irregular cycle and PCOS.
And also when we are measuring the biochemical hyperandrogenism, then we have to stop the COC pills for 3 months. Because this COC pills increases the sex hormone binding globulin and reduces the gonadotropin dependent androgen production, which can affect the results. Okay. So next question is in adolescent women with suspected PCOS, what is the most effective measure to clinically diagnose PCOS related to hyperandrogenism? Dr. Manishi Mittal, please.
Yeah. So clinically most important, I think, is hirsutism only because most of the adolescents will be coming with that complaint. But in the guidelines also they said that acne is also included as a feature of hyperandrogenism, and otherwise alopecia is not very commonly found. So mostly we have these two features only.
Yeah, so this is the presence of hirsutism is the predictive of biochemical hyperandrogenism and PCOS in adults. And alopecia and acne is a weak predictors. So now we go on to next question.
But one more point, Farul, sorry
Yes.
for
Yes,
interrupting.
it's okay.
Must please do a objective assessment. Ferriman-Galway scoring, now the modified Ferriman-Galway scoring of 9 sites is there. We must score it and we must take a photograph of the child. And tell them when they come next time, it is 4 weeks, they should not get their hair removal done.
Yes, we have to take a history at that time also that how frequently they get that hair removal done.
Tell them कि जब next time आप आओगे उससे पहले 4 weeks कुछ नहीं कराना है. And also tell them that the hair cycle is for 3 months. So the coarse hair you have to worry about. The hair will not go. They will become soft and lanular. And the frequency of requirement of hair removal will become less. क्योंकि पूरे तो नहीं जाएंगे ना. They are going to reduce, but they are not going to go. And the treatment needs to be continued for at least 6 months. Before that, no effect.
So for the treatment, we have to give us COC pills for at least 6 months. And then we have to see whether we have to add a second line drug or not. So is there any role of ultrasound in diagnosing PCOM in adolescent patients? Dr. Leena?
Yeah, thank you, Dr. Parul. As already has been discussed,
Yeah.
that ultrasound should not be used for the diagnosis of PCOS for age less than 8 years after menarche. Because we know at this point of time, multifollicular ovaries are very common. So it should not be used.
So there are two reasons for avoiding the use of ultrasound during adolescent, as we are doing mostly the transabdominal, not transvaginal, as these patients are not sexually active. So it affects the accuracy of finding. And secondly, the PCOM, presence of PCOM is a transient condition in these patients. And also, the peak ovarian maturity has not yet been reached, and the AMH is still rising. So defining the PCOM at this life stage is not currently possible.
And
But we
the
should,
last point is that in these young girls, they are already obese. So
Yeah.
the sensitivity of the transabdominal is even further reduced.
Further reduced. Yeah.
So these 4-5 things are there. That is why ultrasound is not recommended for adolescents before 8 years post-menopause.
But I think we should do an ultrasound as such, not to diagnose PCOS, but we can't miss the other diagnoses, especially if patient is presenting with primary amenorrhea or severe hirsutism. Then we have to look for other diagnoses like rare, even if it is rare, then ovarian tumors can be there. Or in case of
Then the
primary
bi-
amenorrhea, we have
So
to
then
is congenital.
other
in
markers
ovarian
will also
tumor,
be
there
quite
will be
raised.
yeah.
Serum testosterone
Very
will be
high
quite
levels of
raised.
testosterone.
Yeah.
Yeah.
And they feel a mass. You cannot do a
Mass.
PCV. And that is a totally different history. Rapid onset and rapid
Yes, that
onset
is there.
of hair growth.
There will
all
be a
of
typical
this.
history of rapid, acute
Yeah.
onset and mass is there. Then you will think of doing the ultrasound.
And signs of virilism as well.
Or measuring small follicles 2 to 9 millimeters on a transabdominal ultrasound, it is really not
difficult.
feasible.
No,
We have
not for follicles, definitely not for follicles, but just to make an overall diagnosis. That
so
is
it
At
may
the
be
moment,
helpful
it's
if
a
she's
valid.
having prolonged period of amenorrhea, like Dr. Abha was saying, and heavy bleeding. So if we
Yes,
want to
that
see
is also.
how is the ET, endometrial hyperplasia, or
Yes, that is what I meant to make an overall diagnosis. We
Yeah.
should not miss out on a ultrasound. Just
But it is not
because-
recommended in any of the guidelines to do a ultrasound for diagnosing PCOS.
Yes, not for
Or other
diagnosing
diagnoses,
PCOS. Yes, we have to rule out because it is also mentioned that PCOS is a diagnosis of exclusion. So we should not miss out, especially after taking the history. All that is important.
Okay, fine. So we move on to next question. Is there any role of AMH in diagnosis of adolescent PCOS? Dr. Ruma?
No, Parul, thank
Hi.
you for that question. It's been a good learning experience, this panel. So anti-Müllerian hormone has now been introduced in the recent guidelines as a parameter that can be used, although values for girls have not, for adolescents have not been established. And the point is that if someone, so I'm just thinking of it as a clinical question, that if someone, a young girl with irregular periods and no hirsutism, came to me and I had to make this diagnosis, and ultrasound is not possible in her case. And although the chance of PCOS or irregularity because of adolescence is high in this case, one of the two, but what I could also, I still have a 5% possibility that I don't know if this could also be a case of POI, where, this is, so no hirsutism, irregular periods, 95% of the chance it's either PCOS or it is generally because of irregularity, which adolescence introduces. So one of the two. But would I sort of completely negate that? Would I rely on FSH, LH, E2? Would I then rely on serum testosterone? Where even for serum testosterone, they say, you don't do direct testing like radioimmunometric testing. For me, then maybe an AMH where established values of 3.5 or 5 and above are good enough to say, okay, she's at least not a POI. This could be a case of her axis is still maturing, or this could be a case of PCOS, which I'll keep her in the reserve. So yes, the answer is already written on your slides, but I'm just giving you the alternative as to would I consider AMH at all or completely reject it?
So what is the answer? I mean, it should not be recommended then?
She has made a very
because
clear...
there are no absolute cutoffs. There are no absolute cutoffs.
Okay,
It can be used as a measure to rule out POI. It can be used as a measure for that, where there are no clinical indications, right?
Okay, fine.
There is no hirsutism, and in that case, perhaps, where you cannot rely on the ultrasound and stuff like that.
It is not a diagnostic test, but as Dr. Ruma said,
It's a supportive.
Because it is going to the same irregular cycles will be in POI and this. And they say that instead of ultrasound, you can do an AMH. If it is high, then you can rule out at least POI.
POI, right.
It could be PCOS. So
This is a very good point, Dr. Ruma.
good point, Dr. Ruma.
AMH is high between 20 to 25 years.
Yeah, but Dr. Picky, Dr. Natasha, sorry, being a panelist, am I allowed to ask one question to ma'am?
Please, please.
Yes, yes.
Ma'am, if you're talking about POI, which was very rightly pointed by Dr. Ruma, shouldn't the LH-FSH levels beforehand tell us about all these things before we are really going radically about AMH?
Yes, we can go for
POI. So which, just a second. So basically, which end of the spectrum she's on? So a lower end of the spectrum might not, also you haven't yet crossed that limit where your FSH is definitely above 40 and your LH is high as well. But we are looking at, the other spectrum where, so it hasn't yet crossed there. It's low on the spectrum where it is beginning to cause irregular periods. FSH, LH you might need to be in the right time of the cycle to be able to ascertain that. If she has come, let's say, in the middle of the cycle, maybe I wouldn't completely rule out an AMH. It is a clear indication. Its negative predictive value is very high for POI. So for me, as in that serves as a good marker for ruling out POI.
Yeah, but a very important point, like if we are going towards PCOS, we are suspecting PCOS, everyone in the audience, for them, it is important to know that in AMH is physiologically high in adolescents. We get follicular ovaries as we discussed, and it may range up to 6 to 7 nanogram per ml. So we should not use it as a diagnostic criteria.
Yes, that is agreed. Not as a diagnostic criteria, only in very specific like this.
Specific conditions, right?
Because as Dr. Ruba said, the LH and FSH levels will not be that high. They will not be at the extreme, but they will be little high. And this can give you, if it is less than 3.5, it is 1 or 2, it will give you a clear-cut indication that she may be a case of POI. You will keep that in mind. Because otherwise in younger girls, younger children, we are generally thinking of PCOS and ruling out, not thinking in these lines. So that is the only indication.
So this is a very important point. So despite the insulin resistance as manifested by acanthosis nigricans and a high insulin levels commonly in adolescents with the PCOS, which is exaggerated by obesity. So this is not recommended for diagnosis of PCOS during adolescence, but the presence of insulin resistance should reinforce the screening of adolescent for type 2 diabetes as a comorbidity. So next question, what blood tests are essential to diagnose the PCOS in adolescent for exclusion of other disorders that can cause irregular menstrual cycles or hyperandrogenism? This is Dr. Natasha Gupta.
Yeah, hi. Thank you for the question. And yes, it was have been a very knowledgeable session myself. So we've already got all the blood tests which also and but in case can you just show the question? Yeah, thyroid test, the prolactin. But in case the total testosterone levels are very high up and pre-testosterone are low. So in those cases, we have to rule out adrenal tumors, ovarian tumors, and Cushing syndrome. So yes, in some specific cases, we need to get the 17-OHP test, the DHEAS test, and you have to first, very importantly, if the patient if the girl is coming with amenorrhea, rule out pregnancy. And the best way we can do is a Was I audible?
Yeah, no. It's a little bit
Your
not
voice was
audible.
breaking, but otherwise audible.
Yeah.
Okay.
Okay, fine. So we
So,
have already discussed all the investigation.
Dr. Parul, I think
I have a
we
comment
should
to make.
talk in this forum about FSH and LH.
Yeah,
They are
I'm just
required to be done. You had
so
written.
to summarize, so to diagnose adolescent PCOS, there should be a irregular menstrual cycle plus hyperandrogenism that can be clinical or biochemical. So first we take a clinical. If there is no clinical hyperandrogenism, then we go for biochemical. So in biochemical, we have to exclude the other causes like assessment of TSH, prolactin, 17-hydroxyprogesterone, FSH, and if clinically indicated, we have to rule out other causes like Cushing syndrome and adrenal tumors. Then if there is only a irregular cycles or hyperandrogenism, which can be clinical or biochemical, then these patients are categorized as a high risk, which can be, we have to reassess these high risk PCOS after 8 years post menarche when they have a full reproductive maturity, right? And if there is a hypogonadotropic hypogonadism due to some low body fat or excessive exercise, then we have to rule out it's clinically as well as by measuring the LH and FSH. So these are the definitions of various high-risk group of PCOS. In this, we have to follow these patients with the lifestyle interventions. So next comes the role of lifestyle interventions. So Dr. Neha Mishra.
Thank you, ma'am. So for an adolescent PCOS, the lifestyle intervention remains the first line of management, as already has been said in the talks. So we should motivate the girl to lose the body weight about 5 to 10%, and we should motivate her to have the foods with low glycemic index, and she should be motivated to do at least 150 minutes of aerobic exercises in a week, and that and she should be for her behavior and psychosocial issues, psychosocial consultations and the motivation should be given. So it remains the first line, followed by addition of other pharmacological interventions.
Yeah, this is rightly said. So in the dietary, there is no evidence to support any type of one type of diet composition. And exercise is around 3 times a week and it's lasting for at least 60 minutes. Now comes the treatment options. Dr. Piki.
Yeah. So treatment we have to start if the child is symptomatic. And as has already been discussed, most important is menstrual abnormalities. So COCs with low dose of estrogen, less than 30 micrograms is what is preferred. And if along with that she has a lot of hirsutism or acne or hyperandrogenism, we can give them progestogens having cyproterone, drosperinone, desogestrone, because these are anti-androgenic. So the importance is that the estradiol is going to increase the formation of SHBG in the liver, which will bind the free testosterone so that the action of testosterone will be low. And the progestogen compound, it is going to cause a feedback on the hypothalamus and pituitary, and LH will be low. So formation of androgens will be low. So two-way the action of COCs is there. If it is a girl who is less than 16 years, we can just give her progestogens, as madam was saying, for the last 5 days or 10 days, because we want to avoid giving her too much of hormones, and we want her to bleed every time so that she does not develop endometrial hyperplasia. And the third thing is
this patient had hirsutism also, acne.
Yeah, I'm not coming to I'm coming to this patient. But the patients who, like this patient, she is obese, she has dyslipidemia, probably you did not get a lipid profile done. She has impaired glucose tolerance, and she has severe hirsutism. So she's a right candidate for starting insulin sensitizers, because that is going to act in 3 ways. It is going to reduce the it is an insulin sensitizer, so it is going to reduce formation of androgens, increase the insulin sensitivity, and improve the clinical, hormonal and metabolic It will prevent her hyperglycemia, and dyslipidemia will also reduce. So it is very important, as Madam has clearly stated, that we must start them on some or the other insulin sensitizers. And if she is not able to tolerate, it is also important to tell them कि we start with 500 milligrams, and slowly every week we start with, we increase the dose to 500 BD, and maximum is 2 grams. And they should take it with meals, and also counsel them that in 2-3 months, the nausea, vomiting, diarrhea, constipation, all those things will improve. The other insulin sensitizer is the myo-inositol, dichloroinositol, and N-acetylcysteine, which are not drugs. They are food derivatives. So they have FSSAI approval. They don't need, it is not in the category of drugs, which is quite safe. And they also have a significant improvement. And hyperandrogenism, I think other panelists can answer. Otherwise, in the end, there are a lot of drugs. I will answer. I will talk about it.
So we have to counsel the patient lifestyle, and first line as a COC pills, which has to be given for 6 months along with the cosmetic therapy. And if there's a suboptimal response to this COC pills, then we have to go for the addition of anti-androgens. And the role of metformin is, as already Dr. Piki has said, when there's a high metabolic risk groups like diabetes, impaired glucose tolerance test, high risk ethnic groups, and there's a BMI more than or equal to 25. And this dose has already been discussed with Dr. Piki. So we can, and this is first case. Next 2 cases will be taken by Dr. Neelam.
Now, Dr. Parul, if she does not respond with this, we can start her on spironolactone, which comes by the name of Aldactone, 50 milligrams twice a day. And you started with OCs because it is going to cause irregular cycles. And another thing is 5-alpha reductase inhibitor, that is finasteride, 5 milligrams. That can be given. Eflornithine can be given for local application. There is another drug called flutamide, which is an antifungal, but it has severe side effects, which ma'am also elaborated. So these are the complete spectrum.
Yes. Okay, fine. So Dr. Neelam will be taking the next 2 cases.
Okay. Yeah. Good evening, everyone. Am I audible?
Yes, you're audible.
Yes, you're audible.
Yeah. Good evening, everyone. All my panelists, Dr. Piki, Dr. Rita, Dr. Leena, and everyone. Dr. Shindu. So most of the part of this adolescent PCOS has been covered by Dr. Parul. Just to differentiate adolescent PCOS from other conditions, which are although not so common, but yes, they should be kept in mind as a differential diagnosis, because if we miss them, then these conditions can have long-term effects on the child's future reproductive and other health. So, yeah. So this is a case where the girl is 18 years old. She has had irregular periods since only 12 months, occurring every 2 to 3 months, menarche at the age of 12 years. So it is almost 6 years post-menarche. And she was diagnosed with PCOS due to irregular cycles, acne, and weight gain. Weight gain was significant. It is about 14 kilograms over 12 months. Despite treatment with combined oral contraceptives given by previous treating doctor for 6 months, her symptoms have worsened. She reports increased facial hair, upper lips, chin, and sideburns since 10 months, difficulty in losing the weight, fatigue, and stretch marks on her abdomen. There is no known family history of PCOS. Mother has type 2 diabetes mellitus. Yeah, Dr. Parul, please change the slide. Yeah. So on examination, her BP was 140 to 90 by 90 millimeter of mercury. Pulse was 108 per minute. Height was 151 centimeter. Weight was 80, thereby making the BMI of around 30. There was no icterus, cyanosis, clubbing, edema, or lymphadenopathy. There was a Ferryman-Garavel score of 12 of this hirsutism. Hyperpigmentation leading to acanthosis nigricans was there. There was centripetal obesity, excessive fat deposition over shoulder, upper limb, dorso-cervical fat pad. And there was bruises and proximal myopathy. Systemic examination was unremarkable. Next, please. So this was her investigation. Hemoglobin was 10. WBC, ASA were almost normal. TSH was normal. Prolactin was normal. Testosterone was within normal range. All these fasting and PP sugar was raised, and her HbA1c was 7%. And on sonography abdomen, she had PCO appearance. Next, please. So my question to any one of you panelists can answer. Given her symptoms and lab findings, what steps would you take to re-evaluate her diagnosis, initial diagnosis of PCOS? What symptoms make you think that it could be other diagnosis?
Yeah, Dr. Neelam, if we go by the history and examination, apart from irregular periods, there's significant weight gain, 14 kg in 12 months.
Yeah.
Then she has increased facial hair, stretch
Yeah.
marks. Typically,
Yes.
she's complaining of fatigue. Her BP is high, her sugars are high, BMI is raised. She has got acanthosis nigricans. Typically, if we go on examination, she has that shoulder hump, which you described, fat deposition. Then a centripetal obesity and a proximal myopathy with stria. So, and Galway is very high, 12. So, all these features, we should keep the possibility of Cushing syndrome in mind.
Yes, that is true. So the point here is that actually we usually, what do we do in our busy OPD, that we see, listen to her symptoms, that she has irregular periods. We just see her chin and neck and see that yes, there are signs, clinical signs of hirsutism, and we label the child as PCOS, and we used to write COCPs. But it is very important to examine systemically also the stria, the fat pads, where are there, and to measure the blood pressure also, and do the sugar and all we are doing routinely. So considering her central obesity, purple stria, elevated blood pressure and elevated sugar levels, Cushing syndrome was considered, and additional tests were then given to her: 24-hour urinary free cortisol, late night salivary cortisol, and a low dose dexamethasone suppression test. This was a real case that came in my OPD, and then we were able to diagnose Cushing syndrome. So due to weight gain, new onset hypertension and diabetes, proximal myopathy and purple abdominal stria, this was suspected and she was evaluated for Cushing syndrome. We sent her to the endocrinologist, and all these tests were done. So this dexamethasone suppression test came out to be positive, and this plasma ACTH levels were also high. So this came out to be ACTH dependent Cushing syndrome, and then we further evaluated her. Next slide, please. And that came out to be some mass in the sphenoidal region. There is another slide, I think.
Dr. Neelam, should I stop sharing and you can share your slides?
Okay, let me see, because there is another slide.
This one?
This one. Yes. So then she underwent this CT scan brain, and there was some mass, and then this transsphenoidal transnasal surgery was done, and she was started on replacement hydrocortisone, and follow-up was done 6 months later. She was not requiring any medication for hypertension or diabetes, had regular cycles, and she lost 7 kgs of weight after 6 months. So the point is to have a differential diagnosis in mind, that yes, she can be some other diagnosis than the PCO. And then these patients are at risk of potential long-term health impacts, and they should be mitigated by early diagnosis and treatment. So my question is, what are the long-term impacts of untreated Cushing syndrome and how they can be mitigated?
She has
Dr.
already developed hypertension,
Yes.
diabetes. Immune system is compromised, so they will be getting number of infections, always getting fatigue, basically, and cardiometabolic heart also gets affected. Chances of thromboembolism are more, MI chances are more. So it is, I think you have highlighted very beautifully with the real case, how we can detect the tumor and get it removed. That is the most important treatment. And to avoid
Also increased risk of osteoporosis and depression.
Yes.
The main thing which came to my mind after seeing this patient was that she had abdominal stria and the obesity was centripetal and hirsutism was very much. So that led to me that it is something else, and I referred her to endocrinologist, and we were able to pick up this Cushing syndrome. So yes, as said by all the panelists, the untreated Cushing syndrome can lead to these severe complications like diabetes, cardiovascular disease, osteoporosis, and psychological diagnosis. And it is very much treatable if diagnosed early. Yeah.
Mortality is very high in Cushing syndrome.
Good case. Good
Yeah.
case.
Now another case is.
I just have a quick question, Dr. Neelam, on the previous one.
Yeah.
How big was the lesion in her sinus, the sphenoid sinus? It's not very huge.
Remember that, but yes, we sent her for surgery to the neurosurgery department because on CT MRI it was some tumor, and she underwent this surgery. I don't remember the exact size, but this was her picture. This is the tumor. Yeah, here.
Okay. And did it cause headache or vomiting or other symptoms
No,
that
no,
would
no
be
symptom, no other
suggestive of
symptom. No.
an intracranial? Okay. All right. Thank you.
We also came across such similar case, and she was finally diagnosed as adrenal adenoma and underwent lap adrenalectomy.
Yeah.
Could be ectopic also at any other place. Adrenal.
Adrenal.
Could be anywhere. And here comes the role of the imaging techniques, CT, MRI. And these patients, we definitely need all these radiological investigations.
So actually, it is a multidisciplinary team involvement and evaluation by the endocrinologist, dietitian, and every radiologist and all this.
Neuro people also in this case.
Yeah, yeah. So next case is a girl, 15 years age, with irregular menstrual cycles that have been occurring every 35 to 50 days since menarche at the age of 13. So she also reports excess hair growth on her face and body along with severe acne that has not improved with conventional treatment. Her paternal cousin has a history of early onset hirsutism and irregular periods. On examination, her BMI was 22, moderate hirsutism of score 10, severe facial and back acne, and no signs of virilization. So, given her symptoms and physical findings, what steps would you take to re-evaluate her initial diagnosis of PCOS? She's 15 and 2 years menarche.
Yeah, in this, the history is very important. Like in this patient, she had this moderate hirsutism coming up, which was
FG score of 10.
Excessive hair on the growth with severe acne. And I think if this comes up suddenly with features of virilization, then one should think of non-classical congenital adrenal hyperplasia.
Yes.
And her paternal cousin also had a similar sort of early onset hirsutism. So
yes, the laboratory
it could be 21 hydroxylase deficiency.
Actually, these are the cases where we actually do the 17-hydroxyprogesterone. Otherwise, normally for PCOS, we don't do 17-hydroxyprogesterone. Only in these heavy cases of severe hirsutism, we do 17-hydroxyprogesterone because we may think of late onset CAH.
So the clinical call is when to do 17-hydroxyprogesterone to rule out each and every adolescent coming with irregular periods. We don't write 17-hydroxyprogesterone. So the thing is when to suspect and write this hormone, because this single test will lead to the diagnosis of non-classical congenital adrenal hyperplasia.
See, in my practice, I always do 17-hydroxyprogesterone whenever patient is having significant hirsutism and I'm not able to find out the cause. Her testosterone is mildly elevated or not elevated. DHEA is also normal, and other things are all also normal. So then I may think of doing the 17-hydroxyprogesterone. That my next step is going for 17-hydroxy. And if the values are more than 200 nanogram per deciliter, then that's suggestive of okay. But because not more than 200, if it is more than 800, that is truly suggestive of CA, late onset CAH. But if it is between your 200 to 800, then we may go for ACTH suppression test, and then we may find out.
Stimulation test.
Stimulation test, sorry. Then
So
we also can find
I
out.
think if the testosterone is not high or normal and she has symptoms of hirsutism, then we should look for these extra things, DHEA, 17-hydroxyprogesterone, and cortisol. We should get these three things done so that we are able to find out. DHEAS is only secreted by adrenals. Testosterone, DHEA, and testosterone will come both from the kidney, from the ovaries and the adrenals. So thinking in those lines, if in the morning 17-hydroxyprogesterone is high, then we will suspect. And as already been told, we can do the ACTH test, as Dr. Rita has said, the stimulation test. And if the levels become higher, then it is suspected to be this.
So this is as told by Dr. Rita, this elevated 17-hydroxyprogesterone is key diagnostic marker. More than 200 warrants an ACTH stimulation test for confirmation. If the post-ACTH level exceeds 1000 nanogram or more than 30 nanomole per liter, it confirms the diagnosis of non-classical congenital adrenal hyperplasia. Next, please. So this question has already been answered, how to differentiate between, So both these conditions can present with hyperandrogenism and irregular periods. But yes, it is confirmed by elevated 17-hydroxyprogesterone levels, especially after ACTH stimulation. While PCOS is diagnosed based on the Rotterdam's criteria. And once we are sure that it is NCCAH, then we can do genetic testing also for this CYP21A2 mutations that can differentiate NCCAH from PCOS. Next, please. So what are the treatment options if we come to the conclusion that yes, it is non-classical congenital adrenal hyperplasia?
Hydrocortisone, which is a rapidly acting steroid, can be given for the younger girls, adolescents, and later on, if she is older, then prednisolone or dexamethasone can be started, because it is the 17-hydroxyprogesterone is being formed and it is not getting converted to the cortisols, to these steroids, glucocorticoids. So that a limiting step is there. So if we give them supplementation with these glucocorticoids, then the metabolism will be better.
Right, rightly said. And we can add oral contraceptives also to regulate menstrual cycles and reduce the androgen levels. And anti-androgens like spironolactone can be added to manage the hirsutism and acne.
That will be, both will be symptomatic treatment, like we do
symptomatic.
PCOS.
Yeah, so that finish off my cases of NCAH.
Thank you, Dr.
Thank
you, everyone. Thank you, the panelists. Yes. Any questions?
Thanks a lot to Dr. Parul and Dr. Neelam. Wonderful cases, and we all enjoyed. Thanks on behalf of all the panelists.
Thanks.
It was a wonderful discussion with a variety of cases. Love to learn. Thank you.
Thank you.
Thank you, Dr. Neelam and Parul.
It is not CAH and cortisol. It doesn't come to our mind when the patient is not responding. We need to be aware of these entities also.
Yeah. Thank you, Dr. Parul and Dr. Neelam, for a wonderful panel discussion. Really enjoyed listening to all the panelists. Thank you, everyone. And now we have a very interesting talk by Miss Sunila, who is a dietitian, and we would be talking about the dietary management in adolescent PCOS. So, hello.
Hello, am I audible?
Yeah, hi, Miss Sunila. Nice to
Hi.
see you in person. Yeah. So I'm really looking forward to your talk, because I have an adolescent daughter whom I'm kind of, because she also suffers from PCO. I'm trying to keep her weight down, and how to manage her diet, because these kids have, dietary fads. So very, very relevant topic you are going to tell us about. So over to you, Miss Sunila.
Yeah, good evening, everyone. Thank you for having me on this platform. Well, as I hope you can all see my presentation.
Yes, we can.
So, in my consulting journey, I normally come across young girls with a prescription in their hand of either oral contraceptives and metformin, and a question to me: do we have to take these drugs? Or if we take a diet from you, we will not have to take these medications. Well, I always tell them, to treat and to manage PCOS, we need a very holistic approach. See, there is no concrete yes or no to this question that we take medication or we take diet, but it all depends from case to case. So my approach to PCOS is always have a very holistic approach in treating PCOS, because it's just not the diet. One advice I give it to them is, do not go in for brand name diets like keto diet, intermittent fasting, DASH diet, Mediterranean diet. No, these do not hold true for any of them. But we need to have more of a practical or sustainable diet. And when I say sustainable, something which they can carry it throughout their life. And our focus is mainly on low GI foods, high fiber, low inflammatory. And the moment we start replacing wheat with different grain as millets, and we all know how millets are good these days for everyone. So we see a lot of improvement in the symptoms of PCOS. So millets, as we all know, are basically very rich in vitamin 3, iron, copper, magnesium, polyphenols. So we are actually very close to our goals. And the top three millets which I pick up for these young girls, because it's very important for them to adopt to this lifestyle. I pick up ragi in besan or idli dosa batters, so that if they have more of iron content in their diet, more of calcium content in their diet, and then I replace their wheat roti with a jowar or a barley roti. So that's another thing which actually helps them lose weight, which is our main focus, and also a little millet. So these top three millets I use. And then, as we all know, a healthy gut is essential, as gut is the second brain. So when we say healthy gut means we need a diversity in the diet. So diverse diet happens when we take different kind of lentils. And in India, we have more than 500 varieties of lentils available. So lentils would be like, any kind of kulith dals or different kinds of chanas, beans, because beans are very rich in inositols. Then we have different seasonal vegetables. I always advise these girls, do not just stick to your bhindi and gobi. Just try to figure out every new vegetable every week. So there can be drumsticks, lotus stems, all seasonal fruits I recommend. But the one thing what I say them is, do not have fruits in the dinner time. So don't replace your dinner with fruits. They should always be taken in the breakfast, mid-morning or afternoon. And then probiotics have a great role in maintaining a healthy gut. So probiotics, a homemade buttermilk or chash, apple cider vinegar and water, kanji in winters, a piece of coconut every day for sure, cow's ghee, fermented foods. So these can be incorporated in their everyday diet. And then we have seeds. Seeds have great role in managing PCOS symptoms, especially to elevate mood levels of these young girls. So pumpkin, melon, sunflower, they all have been seen to have good phytoestrogens. They decrease the estrogen activity and the androgen level. Whereas flax and sesame, I'm very cautious of giving because sometimes they have acne burst outs in this hot weather. Well, there are certain other things which have been seen to get very good results, and they are omega-3 and olives, nuts. Chia seeds have been very beneficial in treating PCOS symptoms. The major reason is they're very rich in fiber, so they help in getting portion control on these young girls' diets. And if vegan diets are also having a great role in managing PCOS symptoms, but if anyone wants to take fish and eggs, that is also recommended for good omega-3. Then there is a huge role of condiments and herbs in water. So any of these waters taken alternately can be very beneficial. Like methi dana water helps in dealing with the sugar spikes or insulin resistance. Then we have chia seeds in water, which is also a very high fiber, and also, as I explained, it takes care of the portion control. Then we have apple cider vinegar in water, whereas ginger juice in water helps in treating inflammation in the body. So, especially with the puffied face, they're very upset, swelling in the ankles, they're very upset. So this has a great role in that. Then we have cinnamon water for the blood sugar spikes. And then there are three herbs which have seen a huge impact, just as aloe vera, especially in managing the irregular menstrual cycles, because they help in, so aloe vera juice every day really helps out in managing cycles because they restore the level of hormones. Then we have curry leaves for the spikes of sugar. And then moringa also helps if you have heavy menstrual cycles. So it restores the hemoglobin levels. Then, as we all know, hair and skin we have great issues with these girls for hair and skin. So coenzyme Q10 supplements help out for having a good gut, and then we can actually have coenzyme Q10 supplements and vitamins E supplements and biotin supplements given along with the diet. So these really help out in managing the PCOS symptoms. Well, I'll just walk you through like a generalized diet schedule, though I believe in a very customized diet for every young girl. But there are certain foods which we include in the day-to-day basis. They really help a lot. So if the start of the day is with any good water and then 5 raisins soaked and a strand of kesar with half teaspoon of halim seeds or garden cress seeds. They're easily available on Amazon also these days. So this has been seen to be very beneficial for regulating menstrual cycles and also to improve the crampy pains of the menstrual cycle and also a glow on the skin. And halim seeds have a huge role in managing thyroid levels also. So start up with this, and then comes your soaked nuts, a bowl of fruits for sure. Now, the bowl of fruits in the morning before going to school helps out in craving, in just pushing off the sugar cravings and to manage the carbohydrate levels also. So, almond milk should be replaced with the normal dairy milk, and almond milk chia seed pudding is really relished by the girls because it's quite filling, and if you add the nuts and seeds and fruit into it. Then your tiffins should always be packed with protein power packed like tiffins, like a cooked sprouts chaat or a black chana chaat or chila with vegetables, besan chila or a little millet upma. So that the energy is there throughout the day for these young girls. And normally when they sit in the bus on the way back home, I normally recommend them to have dates or prunes because they're a good source of magnesium and they improve insulin sensitivity. The meals at home, I always prefer them to have an Indian meal and not ordering in. And especially the chapatis should be mixed with either jowar or quinoa or rajgira flour. And if they are opting for a rice, I do say steamed rice, not cooker or microwave rice, and a hand polished rice, or less polished or hand pounded rice are better because the more the polished rice, the higher the glycemic indexes. And a glass of buttermilk, even if they are vegan, I always prefer a glass of bitter buttermilk or a beetroot or a cucumber raita, because that's a good probiotic what we give every day, especially in this hot weathers. And a turmeric and black pepper to be added in our buttermilk, so that there's a daily intake of turmeric and black pepper, and absorption of turmeric is better if it's combined with black pepper. Then the evenings, I prefer that they should have sattu, especially in this hot weathers, coconut, and then they can go in for your tuitions, or they can go in for their exercise routines, whatever is recommended. I have normally seen that the girls don't prefer an Indian meal for sure in their dinners, and that's the reason that they go in for pastas or breads or any kind of noodles. Or so that's why we need to replace these items with either a quinoa pasta or a millet noodles or a black chana kebab, or any of the fermented foods are very good for the gut. So if they're made at home, or a rice vermicelli, these are better options. And now these are easily available at Amazon with no extra additives, and you can just make them at home. So that's the way we can just have a kind of include all these things in a more interesting manner for these young girls. Well, we all know what all has to be avoided, but I do say that dairy, fresh juices, packaged foods, bakery items, especially breads, have a huge role, and they are just a factor which doesn't let the weight go low. And as I mentioned earlier, well, I'm not much in favor of soya also, because at times there are a lot of hormonal disturbances and thyroid levels go up and down. So I really don't prefer a soya milk or a tofu, and obviously no red meats. Like, as I said, we need to manage PCOS with a very holistic approach. So I do not consider walking at all for them, well, aerobic exercises or any classes you join, but I do advise that Surya Namaskars are a must, because they can be done very easily in the four walls of a home. And butterfly asana is very good for their PCOD and for ovaries also. So, but I recommend that you do have a vitamin D and calcium supplements, which actually gives them a boost to do exercise, and they don't feel low. And so another thing which is seen, that if the sleep times are not great, then it is very difficult to have a weight loss or even hormonal disturbances to be fine. So I do recommend a magnesium supplement before bedtime. And this sleep time is actually interfered by the telephone thing. So the mobiles have to be switched off, or they have to be out of the room 30 minutes before the sleep time, or else it's very difficult to get charge of this. And so small things like cycling, stationary cycle while watching TV. So that helps in actually increasing the metabolism to maintain a good weight. These all things are quite essential. And if these girls have to study late in the night, that's the time when they get haywire, the whole routine goes haywire, and they just get to any of these packet foods or chocolates, or so a bowl of papaya, nuts, almond milk, spearmint tea, or a chamomile tea. These all things really work well if they are introduced into their daily life routine, and it's just a change of thought process that we see, that this is the way we actually deal with PCOS and manage the symptoms well. Well,
Thank you so much. Thank you so much, Ms. Sunila. So I have a question here. Why are you saying to avoid milk and milk products? What do you have in mind when you say that?
So actually, to improve insulin sensitivity, dairy has not played a great role. That's why I said even I don't uh, curd or buttermilk. And secondly, normally in India, people take market paneer, and market paneer is loaded with milk powders. So that's the reason. And there's a lot of acne breakout. The moment you stop dairy, the skin gets clearer, the HbA1c levels, the fasting blood sugar, weight loss. So it has been seen. And the quality of milk what we get, if we take it as that, it just doesn't work very well for the gut. So the constipation. So there are a lot of issues related to overall health which are actually addressed well when we stop dairy and like a milk kind of a thing.
Okay. One more question, Ms. Sunila. When you're talking about those waters, chia water, and how do you make it, that water?
Yes, it's a very simple thing. Any of these herbs you take, for example, methi dana water, you just soak methi dana in the half teaspoon in a glass of water overnight and just drink it strain it and drink it in the morning. So that's a chia seeds water also, a teaspoon of chia seeds, soak them in a glass of water overnight, and then you can drink it in the morning. These days, you don't even need overnight because it's too hot. So basically, a few hours, maybe do it in the morning, and then when the child comes back from school, just give it them in the evening, not in the afternoon. So it's seen that, it's very rich in fiber. When you have chia seeds water, you actually have a portion control in your meals.
Yeah, got it.
Sunila ji, one question I also wanted to ask. So you recommend that dairy should not be prescribed for us, for pregnant patients, everybody? Earlier
No.
we used to say that
Pregnant patients, no. we're just talking here about adolescent PCOS.
This is just for because leaky gut and all those things.
Yeah, for
Insulin
leaky gut. Yeah,
Absolutely
exactly.
not
For a
everything.
healthy gut, yeah. Pregnant patients, it's very individual. I tell you, if a lady comes to me and says, I'm like, in any kind of gut issues, whether it's loose motions or constipation, then I do replace it, but I don't ever replace it with a soya milk. I replace it with a homemade almond milk.
Okay.
So that works very, very well in some certain cases, but it's not a thumb rule for pregnancy, not at all.
What about for us, our age people, middle age?
I believe we should not take milk.
Yeah, milk has earned a lot of disrepute over the years, I realize. Yeah.
I tell you,
all our previous people
the demand of
we have been reading that milk is a wholesome meal and all those things.
Yeah, we've been reading that, but the thing is now the demand in India of milk is quite high and the production is not that great. So we have been getting a lot of hormonal injections to our sources, whether it's cow or buffalo. That's the reason we have so much of PCOS at present, because we have had this thing, get up in the morning. I come across cases where the milk is given to the child right in the bed itself, and then the girls wake up. So that's the way it has been there.
So does it make a difference ki bed pe mile ya breakfast table pe? Does that?
No. Actually, no. It has to be stopped if we have to manage PCOS. If there are symptoms of PCOS, and see if the child is healthy, doing well, there are no issues, I do never recommend to stop milk. But if there are issues, the body is showing something, and we need to treat them. So then obviously I would recommend to take off milk. And then I I never stop homemade curd for sure. But even paneer, I start when I see the symptoms are being managed, weight loss is happening, things are going well, then I tell them to start homemade paneer, mixed with vegetables and then regular diet.
Madam Sunila, how do we have to take this cinnamon water? Do we have to boil this cinnamon in the water?
No, we don't have to boil it, madam. We just need to add cinnamon and water and then just drink it as a drink.
Like that soaking overnight?
No, not overnight also. You can just take it. Normally, cinnamon, I also recommend it in any of their drinks because it's a natural sweetener. So
So can we put her in a water bottle, the cinnamon?
Sorry, I didn't get it, sir.
So in our water bottle which we carry for our work, can we put cinnamon in that?
Actually, yes, we can do cinnamon water, and also especially when you have sugar cravings. So when you take cinnamon water, your sugar cravings go low. So they have a huge role in managing the insulin resistance. And especially whenever you take a water bottle, you need to add some jeera, some mint leaves, some ajwain into it. So then your gut remains healthy throughout the day. You don't have gastric acidity. See, we all have more of sitting jobs. So you have something which you just take your liter of water bottle, just add a little jeera, add 5-10 mint leaves, Have 1/4 teaspoon of ajwain, and you can even add some basil leaves, and then just take that water and keep on drinking the water throughout the day. That really works very well.
Even without grinding, ऐसा ही पूरा
Nothing. Don't do anything, because they just leave there, and the whole day just keep on drinking that water. There's no need of grinding.
how much if we are prescribing, I'm just taking the opportunity because you are here. If for
Yeah.
pregnant women, which type of milk, mother dairy milk, do you advise? Because I see many of them taking full cream, which I don't
I recommend only cow's milk. If you can get it from an original nice source, well and good. Otherwise, cow's milk.
Mother dairy ka cow's milk, not toned or double toned.
Cow's milk is the best. It's the lightest on the gut. It's digested very easily.
And what is your take for intermittent fasting now?
Only young girls getting married have a deadline. And I'll tell you, it works only for 3 months. That's a research.
Okay.
For all of us, if we start doing it. So initially, if that's why I said if you have a deadline, it's good. But it has seen over a long period of time, it creates symptoms like gut disturbances, like acidity, acid reflux. People come after some time and say, because 16 hours, you are just not having anything. And then you just start. So it works very well with the younger crowd. So I just don't say, okay, don't do that. But for the younger crowd, it's better. For women above 50, 40, it depends if it depends if you do not have any symptoms, you can do it for a short time, but not for a longer period of time.
I wish Dr. Ruma was here because she's a big proponent of intermittent fasting. Yeah. And she does it herself. So
No,
it was so
works.
interesting.
See, all these diets are individually dependent. So there's no like one thumb rule. If I start intermittent fasting, I might get acid reflux. I can't be, and I get migraines, I get headaches. So then it doesn't work for me.
Yeah.
So it's not like
I want to make a comment here, Rita. My brother is 60, and now it's 4 years or 5 years he's doing intermittent fasting. His all anti-diabetics have finished. He lost about 15-20 kgs in the first year of intermittent fasting, and he's just on metformin. He was a very highly diabetic person. So it does suit some people. And
Yes, ma'am.
16 hours is a lot, I agree. But even in our and your milk theory, I agree 100% that humans are the only species which drink other people's milk. We don't need to. In fact, there was a lot of debate on donkey's milk. And they said donkey's milk is very expensive and very nice. So, there's so much debate that we are trying to capture everything. We eat other animals, we drink their milk, we use everything what other people have. But regarding intermittent fasting, in our Indian Shastras, evening meal was by 7 o'clock, and morning 7 o'clock you would have your first badam and milk. So 12 hours fasting is very
12-hour
good.
fasting is, I also recommend, I always say end up your dinner by 7 p.m. and start your day by 7 a.m. So that's a natural way of doing things.
Yes.
That is
I agree that for all of us, this is the
for all
best.
of us.
But there are people who were overweight and who did intermittent fasting,
That
and
works
it
very
helped
well,
them.
but it works for some, it doesn't work for every. So it can't be a thumb rule for everybody. I agree with you that way.
And regarding paneer, your observation was so correct. I've been told that there is so much paneer in Indian market. Do you think that so much milk is being converted into it? It is a subsidiary of milk which makes paneer, and we eat it. Shadiyon mein, there is like tons of paneer being served for everything in a vegetarian shadi. So where does it really come from? Real milk, or it comes from arrowroot and everything mixed into that paneer?
It's just the commercial milk powders which are making it. I have actually
They are
inspected
not
myself.
milk powders. They are just arrowroot.
They're actually the non-labeled milk powders, which are actually being made for paneer. And that is the reason I just say no dairy as a thumb rule for start of it.
No
And then I
paneer
say
made outside, but paneer made at home is from real milk.
Yes, that is good. So cow's milk paneer, if you make it at home, mix it with vegetables, give it to the child twice a week, thrice a week, is perfect. But if you do
Buffalo
it from
milk?
market paneer, no.
Buffalo milk?
Buffalo milk is actually not. See, I'll tell you what has
Rich
happened
in
now is
fats. Rich in fats,
yeah,
na?
no, the buffalo milk, every buffalo in India is actually given a lot of hormonal injections.
Oxytocin.
So, yeah, so that's one thing
Very
which
interesting talk. I'm sorry I took a lot of time and your time is already over.
no,
I
that's
just
okay.
jumped into it because I was
Yeah.
listening to the
No,
very
it was so
interesting discussion.
nice to hear from you, madam.
It was very good to have you around, Miss Sunila. And
Thank you so
I don't
much
know
for
whether
having me on
others
this
are
listening
knowing,
platform.
she is, she's in US right now, and it is early morning for her. And she obliged us by joining. Thank you so much,
No,
Miss
no, thank
Sunila.
you.
And we will bother you for our other programs also whenever we need
Sure,
you on board. We'll bother
sure.
you again.
Thank you
Thank you
so much.
so much. Thank you.
Thank you so much for having me.
Dr. Neelam, are you there? I think Dr. Neelam has also left. Are you there, Dr. Neelam? So I can raise the vote of thanks. Thank you to all the faculty members who are there, the panelists, the moderators, the faculty who gave lectures. Thank you to everyone. And thank you to delegates who stayed till the end. And those who joined earlier also. I'm sure it's a working day. It is difficult for everyone to join. But thank you so much. And thank you, Dr. Picky, for
Thanks.
your active participation. Thank you, Dr. Leena, everyone else. Thank you. Thank you.
Thank you, Dr. Kethi, and everyone. Thank you so much.
Thank you.
Thanks to
Thank you.
everyone. Thanks.